don't know why I got it.
Are we all here, please?
Anything about that, isn't it?
You got a card?
Quickly.
Can I double check?
Yeah.
I'm just recovering now.
Or could you just shut the door, Andrew, for me? Yeah, okay.
Indeed.
Thanks, Charlie.
Hearing aid for Andrew.
Who can tell?
Yeah, it's just like you can't be weekly.
Over time.
Can you?
Just refer it.
Yeah.
Good job it was you.
Yes.
So shall I call us to order? Feels like my voice is very loud through that microphone. Is that all right for you all?
That's perfect.
Okay, not too grating, I hope. Good morning all. Welcome to our November meeting of the board. Just so you know, this is a public board meeting, so we're being live streamed. So welcome to all of those who are watching our meeting live. I've got a few apologies and a few welcomes. So we've got apologies from Stephen Eames. He returns from his adventure tomorrow. We've apologies from Nigel, who's having an adventure in India on a recruitment mission for our system. Apologies from Jane, who's having less of an adventure in London at an important NHS meeting. Simon is here and Michelle is here. Not apologies. And Louise Wallace is unwell this morning, so she's been unable to join us. So some apologies and some welcomes. So particular welcome to Simon Stockhill, who I think most of you will know, our primary care collaborative lead. Simon's joining us for the whole of the meeting, and I've said I'd be very happy for him to participate in the meeting in the normal way. Welcome to Emma Sainer. Emma is deputising for Jane Hazelgrave. Welcome to Peter Thorpe. Peter Thorpe has joined us as Director of Strategy. Is that your job title? Exactly. Yes. Welcome. Peter, until recently, was the Chief Executive of North Links Council. He's been a great ally to our developing partnership, and we're really, really pleased to welcome you. You'll find it very interesting today, I've got no doubt. And the other thing that we've got to do is welcome back Mark Chamberlain. As you'll know, for the last 6 months, Mark has been acting chair at York and Scarborough Teaching Hospital. I think he's done a great job of that, but it is the case that personally, and I think other board members have missed him enormously. And actually, I want to give you something, Mark, because I think what you did was beyond the call of duty, really.
Oh, thanks, Sue.
Well done you, thank you.
Oh, thank you very much.
Okay, so that's our apologies, that's our welcomes and introductions, and it says on my notes that for the record this meeting is quorate. Item 3, declarations of interest. Are there any changes to the declarations of interest? Thank you. And you've also received a copy of the minutes of our meeting held on the 13th of September. First of all, I'm going to ask you, are there any points for accuracy in those minutes that anyone would like to pick up, please? Well done, Emma and AI, for accurate minutes. And any matters arising that don't appear on the agenda that anyone would like to raise from the minutes? Karina.
Chair, if I may, just that there was an action in relation to the Constitution, bringing that back to this meeting. We've actually deferred that to the next meeting just so that we can make some adjustments and changes so we're not bringing it backwards and forwards to this meeting. So
lovely, Karina, thank you. Anything else? We did have some actions. One was the finance report. Jane completed her action, thank you. The mitigating actions in relation to AI and the new estates risk completed in terms of the BAF, and the response following the Lucy Letby stuff is deferred to the December meeting, and that's the constitutional change I think you might be referring to, isn't it? the Voice of Lived Experience Committee update is here on the November agenda. So as far as our matters arising are concerned, we're done. I haven't had any notification of any other business for this meeting, and I'm thinking no one else has brought any with them today. Thank you. Let's go in that case to the Board Assurance Framework. So just to remind you, we do this every month, and maybe for those who are observing us today, this is useful knowledge. The board is obliged to document the key risks as it sees them in respect of the achievement of our strategy. And we do that in our board assurance framework. And the clue is in the name. The purpose is to assure the board that we're taking all possible action to mitigate against the risks as we see them. It's a dynamic document. We're able to update it, to update the risk analysis when we want to, but it keeps the board honest in respect of ensuring that the board discussion relates to the risks as we see them. We also look briefly at the board assurance at the end of the meeting too, to be sure that the things we've discussed are the things that relate to the greatest risk we face. So there are some changes to the BAF. I think probably Karina is going to talk us through those, or are you going to, Mike?
I will do, Chair.
Yeah, thank you.
Yeah. So I think there are, as you have quite rightly pointed out, Chair, there are a number of changes to the board assurance framework this month. There is some real significant progress as well in terms of mitigating some of the actions, and all of that's documented. I will just focus on the big changes for the board. So the first one is in relation to risk reference A1, which is the patient safety and positive health outcomes risk. This was discussed extensively at the Quality Committee in October, and they've asked for a slight reframing of the risk. There were some concerns raised, and Teresa may want to add to this, about the use of the word affect fundamental standards, and how we would be able to show that in the year when we're managing this as a risk of about what's happening in this year's 23-24. So they've asked for a slight change to just say that they are monitoring and mitigating actions to improve standards, and in which case they can then evidence some pieces of work that have happened that will mitigate that risk, and therefore they would also like to adjust the likelihood and score for that from a 20, making 15 rather than 20. So I don't know if Teresa, because it's a particular risk.
It's built on lots of conversations we've had at previous quality committees and at the board in terms of that wording and the ability to affect improvement within the year across a range of quality and safety domains. And obviously meaning that because of the wording, we weren't in a position to actually change the scoring, and it would stay at 25 basically all the time. So after much deliberation, excuse me, we agreed that we would suggest a change in wording which better reflects the activities that are underway to improve quality and safety.
Okay, all right, thank you. Any comments? Thank you. Karina?
Thank you, Chair. And then the other one that I really just want to highlight today, I think you've referenced it already, Chair, which is the estates risk. Following conversations at previous meetings, we've developed in conjunction with Jane Hazelgrave and Steph Porter a risk that reflects the estate issues that we're experiencing and how we're mitigating those.
Thank you, Karina. I think all the board felt that that was an important risk to have on that board assurance framework. And there's much work to do about premises in all sorts of different ways. So a very important thing for us to keep track on. Any comments about that? No, thank you. We've deliberately put the Voice of Lived Experience as the next item on the agenda. Oh, sorry, Charlie.
Sorry, I thought you were, apologies, Chair, I thought you were talking about the estates thing. I wanted to probably lay a bit of a marker on probably B4, which is the workforce risk in the Managing Tomorrow section. And it's motivated in part by a report of a conversation I heard from the York Place meeting recently, where a colleague from York St John University was saying, wonderful to have this NHS workforce plan, but nursing applications are falling, not rising, and placement supply is at a critical level already. So there was a sense there that it's going to be actually pretty much impossible to deliver that plan unless we, this is not just a Humber North Yorkshire thing, unless we find ways of tackling some of those deeper issues. Now, I'm not suggesting this is a big discussion for now, but perhaps a marker for the future to bring people together who can have an influence on workforce supply to see if there is a way of matching the increase in demand for workforce that the workforce plan sets out.
Certainly. Jason, you might want to just say something there.
Yeah, thanks, Charlie. You raise a really important point, and one of the challenges that sits within the long-term workforce plan, but we do have the Education Committee, which is tackling just that, and I think one of your colleagues from York University is chairing that for us.
Jason, I don't know if you want to make a comment.
I think it's one of those, it's the conversation, I think the huge advantage of having the university around the table in terms of the workforce board is very much, we are very conscious that we need to really balance the way that we think about placements in the future. I think there's quite proactive kind of conversations happening around the type of roles, what needs to kind of change, how we have a very forward kind of thinking conversation. But the Education and Training Committee, which Jane's kind of talking about, led by a university which is York and by a college which is Hull, I think is starting to kind of look at what the opportunity is, but also how we make best and most effective use of funding that's coming in for education. Because I think some of this is about how we use resource or think about using resource differently rather than continuing to do what we've always done. But the demand is incredibly high, and actually there are elements of that workforce plan which I think we know are unrealistic without additional resource coming into the system and coming into our schools and colleges as well.
Thanks, Jason. That's helpful. And I think no doubt this will be part of work that Peter's also interested in as we start to look at our longer term strategy. So it's a point well made, Charlie. Thank you. Anything else? Okay, well, let's move on to item 8. I do want to say how pleased I am that this paper is here. I do want to say how important it seems to me to be prefacing our board meeting with the comments of those that we serve. That feels hugely important to me. I thought the quality of this paper was great. And the other thing that I saw today, better than I've seen before in our board papers, is how this voice of lived experience seems to be evident in all of the papers that have come to board, and I really, really welcome that. That's such an important thing for us, and I hope all of you had the same feeling as you were reading your board papers. Actually, they're starting to come together, and we're starting to see a whole rather than siloed reporting. In any case, this is over to you, Anya, so thank you very much.
Thank you, Chair. So I'll take the two papers as read. So the first is the engagement dashboard, as we're calling it, which is pulling together, particularly at this point in time, the key information that is available through our ICB channels in terms of understanding public and patient voice and experience, and working with our colleagues at Healthwatch. I'll come on to some next steps in a second, if that's okay. Just in terms of the key themes, very similar to the last dashboard that we presented, you couldn't imagine actually that things would change significantly. So still the sort of primary concern, as it were, is around both perceived and real access to services, mainly primary care, but also mental health coming in this time as opposed to dentistry. Not saying that dentistry still isn't an issue, but that is a slight change. And also a sense of a growing concern around issues relating to travel to appointments. And a lot of this has come out in the conversations that we've been having actually as part of the Humber Acute Services consultation events, that as a sort of unintended consequence, but very relevant consequence, a lot has been fed back around that, and particularly in the context of the cost of living challenges that many parts of our community are facing. waiting times and again perceived and real difficulties in making appointments continue to be at the sort of top of the list, as it were, in terms of concerns. Just very quickly before I move on to the other report, just to update on some next steps around this work. So firstly, and if you recall the information that has been presented before, this was about starting to pull together the information that was available within the ICB and Health Watch, but we always had the aspiration to broaden that out to other partners, particularly our local authority partners. So we've got a second workshop taking place on the 11th of December to do just that. And sort of in the background, as it were, we are working on a repository that is really taking shape so that we can pull all this information into one place together. So that workshop will take place on the 11th of December. And we're also delighted to launch our inaugural patient engagement network on the 22nd of December, whereby members of our PPG networks across the patch, residents, VCSE, members of public groups and local authorities will also be invited to that. So I look forward to providing an update at the next board as part of the dashboard. I'll move on, if it's okay, to the sort of deeper dive report. And if you recall, as a reminder, we had committed to do this important work. So last time we had the findings of the NHS 75 work that had focused on conversations taking place in some of our core 20 neighbourhoods. So some of our neighbourhoods facing the highest levels of deprivation. And you'll recall, hopefully, some of the findings from that. This time, the focus is on, and rightly so, on our LGBT plus community. I think I did touch on it at a previous board meeting that this work was happening. To put this into context in a number of different ways, you may recall from our overarching Working with People and Communities strategy, we have made that commitment to putting almost a disproportionate effort into really understanding and working with the areas of our community who we find harder to engage with and whose voice is not normally or very readily understood and heard. And so this is why there has been a focus on our LGBT plus community. We know from the national evidence that is available that unfortunately members of the LGBT plus community face some of the most significant health inequalities, both in terms of health outcomes and also in accessing services. Around about 3% of our population officially class themselves as LGBT plus, but it's likely to be much higher because we know there are still many members of that community who don't feel, for whatever reason, that they can say that they are part of that community. So this is a really important part of our community that we're looking at here. Again, I will take it as read that you have read the report, but I will just pull out some key headlines and themes and next steps. And again, this work has triangulated some of the intelligence and data already available through our partnership and also conversations and activity that took place at various Pride events over the summer period. You will see from some of the headlines that I will just pull out that probably relates more to the ICP agenda as opposed directly to the ICB agenda, but still very relevant and very pertinent. So about a third of our community have experienced negative attitudes. 3/4 have said that they have been threatened, harmed or abused as a result of being LGBT+, and 3/4 have said that they have felt or been discriminated against because of their LGBT+ status in work, education and in accessing health and care. Now, I find those incredibly sobering, and particularly where we are today. I don't think any of us feel comfortable at all with those findings. Drilling down a little bit more into health and care, obviously our agenda for today, 1 in 8 have reported experiencing unequal treatment from healthcare staff, and 1 in 4 have witnessed discrimination or negative remarks from NHS staff. So there is a huge amount for us to do in respect of this agenda. It won't then come as a surprise that some of the themes coming out of the insight are around barriers to accessing healthcare care. So some of those are similar to what we've found in other parts of the population that are very well versed, and again you have seen in the dashboard summary. But again, particularly in relation to our LGBT plus community, 1 in 7 are actually saying that they avoid accessing health and care services for fear of discrimination. So they're not actually presenting for that fear of discrimination, which is very worrying, and a sense of a lack of understanding around support and services available both directly and indirectly. Very key theme around improving health and care for LGBT plus people. Of course, you would expect that, and particularly themes around flexibility. And it will be useful, I think, for us to triangulate that in terms of some other sort of demographic trends, and particularly around young people from other pockets of our work. There is a signal that actually they want greater flexibility in terms of digital out of hours, because they're working and they find it hard to get access to some of those things. So a bit more of a deeper dive on that one. But promoting services both directly and indirectly in terms of those services that are available specifically for members of our LGBT plus community, but also LGBT plus friendly services, if I can put it like that. And trans education in particular has come out that there appears, or there's a sense that there's a lot of misunderstanding around how to support our trans community from a health and care perspective. But the flip side of that is that there was a lot of feedback to build on some of the good work and to share the good work actually happening in our system. So a particular example was some of the work that is happening at Huth in terms of really supporting the LGBT plus staff and patient community there. So real opportunity to build on the good work. So again, you'll see the recommendations in the report, but very quickly, to have more consistent engagement, and again, particularly with the Pride events over the summer, this was bringing together our wider health and care community to engage, and that worked really, really well. And I know that the staff involved in that also got a great deal out of being involved in that activity, some of whom are part of the LGBT plus community, as you would expect, to identify and invest in education and training. Again, you'll see some of the further insight that is suggesting that there's a big opportunity to improve around education and training amongst our workforce, to facilitate those opportunities to share and build on good practice, particularly to support our primary care colleagues and networks, to build on our digital hub. So you'll recall a few board meetings ago that we brought the Let's Get Pride in Our Health hub, which is part of Let's Get Better, and again to build on that as a space that collates the information for our LGBT plus community, and continue to share this information and this report across our system in the same way that we did with NHS 75. So I'll stop there, Chair. I hope that's a helpful summary.
That was very comprehensive, Anya. Thank you very much indeed. I would just draw your attention to the HNY Inc. document on page 33 of my document. That is just so useful. I think it's your publication, Jane, is it? Yeah. Really helpful. I'd encourage all board members to make sure they've got a copy of that and read it carefully. It's a great way to orientate yourself. So I really heartily recommend that. The other thing that that really struck me when looking at this report was in the early part of the report where we hear that people feel frustrated they can't get a GP appointment, not in the way they want, etc., etc. And yet when we look at the primary care paper in this pack, it's almost a direct answer to the question raised by Healthwatch. So that felt very helpful to me. I really approve of this report. I'm really pleased it was here, and I'm interested in comments from everyone else. You first, Jonathan.
Yeah, yes, thanks, Chair. Going back maybe to the insight summary, I don't want to miss the opportunity to mention transport again, because I know it came out of the North Yorkshire Healthwatch report. I'm sure North Yorkshire, North and North East links have things as we do about transport, the links with community transport particularly, and I'm just really a plea of how we can collectively, it might be an ICP issue, but how collectively we can start maybe having a work stream around transport, because there's a lot of work going on, and I think in the last certainly 5 to 8 years there's been vast improvements in coordinating
Yeah, I think that's a really good point.
I just want to keep flagging that when I get the opportunity from a authority point.
And where something good's going on, let's hear about it, and where we can develop it, let's know. Yeah, Michael.
I just thought, almost as a related comment, whilst this report was, it's clearly focusing on LGBT and the negative attitudes and the discrimination that they are reporting that they suffer, I think it just chimed with me that a fortnight ago I had a meeting with Horizons in Harrogate that deal with prison release and people with drug and alcohol, and there were similar messages but for a different reason. Yeah. And it just struck me that I think we should all be just mindful that we will see discrimination, we will see negative attitudes, and it might be the theme of prisoners, it might be the theme of trans, it could be anything. I just think we need to be aware of it and call it out when we see it. So whilst this is on one theme and is perfectly acceptable to draw this one out, we'll see it in others. An old lady doesn't get discriminated in A&E because she's fallen over, but a prisoner might. Yes. Or a trans person might. Do you see what I mean?
Yeah. No, thank you. It's a really useful contribution. Jason, then Helen.
So just in response to Jonathan, so the community transport thing is really important. So we're bringing together through the VCSE Collaborative a roundtable event to talk about community transport on two kind of levels. One of which is the medical aspect, getting to and from appointments. The other bit that's kind of figured quite strongly has been for some of those activities, particularly in rural communities, East Riding, North Yorkshire, around getting people from A to B to go to that coffee club, to go to that sport group, is actually, do we really understand the network of community transport options we have, but also what's the power as a collective to say we could do more with community transport. So I think, people came to us and said, we want a conversation about it beyond the getting picked up at 5 in the morning to go to a hospital appointment to something much more. So I'm really hopeful what will come out of that round table is a set of actions collectively around understanding the market, but also what we could do to develop the market. I think that's going to be really, really positive. The other bit, and I think I really like this report, and I think there's something for me about, Anya talking about building the engagement family, so building all those kind of networks so we can have one conversation around patient experience, but actually there are lots of different dimensions and perspectives, and I think that's what we're kind of talking about, because everybody's experience is valid. There is something for me about teasing out some very specific issues for LGBT plus communities, which are in there as well, which I think merit conversation on their own, because I think it's interesting to know a perspective on primary care, interesting to know a perspective on accessing A&E or whatever, but there's some very, very specific asks, I think, coming out of here, which are quite tricky asks, because actually some of the things people are asking for are not solvable overnight, as Teresa knows. Teresa and I have been in this arena for quite a long period of time. But also some of this is almost, I think around this is the network that sits around the support for communities as is important as accessing communities. And I think we probably don't have as good an understanding of what that support network looks like. And I think part of what we need to be able to go back with is this is where we know the support is coming from within communities.
Thank you. Michelle. Oh, sorry.
Yeah, thanks, sir. I mean, it is good to see, and we did say we wanted to start the board off with lived experience and service use of it. I suppose I'm just a little bit confused in relation to how this fits in relationship to the plethora of work that's already taking place across the patch. You alluded to it, really great presentation and well presented, because, I mean, I think as other colleagues have said, you can put a lot of the issues and themes across multitudes of different groups of protected characteristics, but there's a huge amount of work going on within organisations. For example, we've just introduced a respect campaign across all the protected characteristics, and that's just not, but we do lots and lots and lots in relationship to service user as well. So it's good to see it. I just wondered what's the role of this board in relationship to it. Is it that oversight to see what's particularly happening at place, what's particularly happening in providers, or is it to do something separate? And I think we just, maybe not now, but I just think we need to think about that definition, because if not, we could end up duplicating and asking a lot of similar questions and then getting a lot of frustration to say, well, we keep saying this and nothing happens. So I just think that for me, it's something that's probably more centralised in place to link in, but just an observation. And the other thing is about the membership as well, because obviously foundation trusts have memberships by statutory instrument. So we've all got membership organisations. So how are we utilising those members? We've got a massive cleanse on ours, for example. So how are we linking in those in relationship to this? So I think great report, good to see it, very well presented, sets out some of the things. But for me, it's that strategic direction of that information and what we want to maximise our contribution as a board.
Thanks, Michelle. When we first got together to talk about this, we were aware that there are so many groups of people doing so many things in this area, that the briefing is how do we bring all that together to give this board some assurance that our work is geared to delivering the needs of the population that we serve. That was the initial conversation that we had. So no desire to duplicate at all, and plenty of respect for what goes on individually all over the place. What we need is something that this board can relate to. Helen.
Yeah, so just building on that, so one of my aspirations when we started this piece of work as well was not only to triangulate everything that we're hearing across the system, but also to start developing this dashboard to kind of pick out what we aren't hearing about as well, so we can direct some of that engagement, and particularly around what are some of the drivers of inequality which don't generally come up in your day-to-day engagement, or what people proactively feed back. So what isn't in here at the moment, so at the moment it's given that kind of temperature check, but as it evolves it's going to show more of those deeper dives. So for instance, some of the deeper dives that Health Watch are doing very much mirror the findings that Anya said around LGBT and what Michael's raised. So for instance, in Hull we're doing a piece of work around rough sleepers. Feedback from them is very much the same as what Michael said around feeling stigmatised, not wanting to be conveyed to A&E because of how they've been treated in the past. So I think as this moves on, we'll start to see a lot more of that coming forwards and be able to direct actually what aren't we hearing about that we do want to know about, and be able to do that in a bit more of a structured way.
Yeah, thank you. Thank you all for your contributions. What's for sure is we're further forward than we were before we had this report, and I'm grateful for that, so thank you very much indeed. You'll notice that what I didn't say at the start of the meeting was, of course, we've got Amanda deputising for Stephen today, and I perhaps should have said that. So for the Chief Executive update, I'm pleased to hand over to Amanda Bloor.
Thank you very much. So I've just got a few bits and pieces to go through this morning. First of all, just to say that we were delighted to host Amanda Pritchard on Friday, the Chief Executive of the NHS. She visited Hull, and we had a packed agenda. A number of colleagues around the room were involved in either organising that or being part of it. So she visited the Jean Bishop Integrated Care Centre. We then went to the neuro rehab ward at Castle Hill and saw some particular innovation around artificial intelligence around neuro rehab, and Amanda got the opportunity to test some of that and use it. We went to the radiology day case unit at Hull Royal Infirmary, and she also went to Rossmore Community Rehab, accompanied by Andrew and his team. But we also met a lady called Jeanette Robinson, who's a housekeeper, and she's worked in Hull, different sites across Hull for 50 years, and was born in the same year as the NHS. And I have to tell you, there's an article, I think, in the papers, but what an inspiring, energetic lady she was, and very affectionate, so she gave us all hugs. So I know that in talking to Amanda, she was really inspired by the level of integration that we saw in Jean Bishop and at Rossmore, but also the passion and commitment of the clinical colleagues that we met in Hull. So, and she wrote about that in her blog. So that was a really successful visit. Another couple of things to mention that we've had over the last couple of weeks was the Child of the North Symposium that a number of colleagues again were speaking at and hosting, attended by senior leaders from across the partnership really, which is a real tenet of the work that we're doing to focus on the challenges faced by children and young people across our area. And it was the first symposium, I think the first of a programme, well received. And then just to add, yesterday we had the launch of IRIS, which is the Innovation Research and Improvement System, which we've talked about here at the board a number of times, and really underpinning the work that we're doing collectively around the future and the future transformation. And again, a number of colleagues were here. I just want to mention the smoke-free consultation launch. You may have seen the blog that Sue and Stephen and I sent up to NHS Voices and our support for that. And Stephen and Sue have signed a letter with partners around our support for that. The 8-week consultation was launched on Thursday the 12th of October, but it was the standout policy in the King's speech yesterday in terms of reforms and actually creating that smoke-free generation, and such a key link between that and the population health paper, where you can see the impact of smoking on poor health. So starting to really make those connections. And also linked the Centre of Excellence for Tobacco Dependency, again, that we've got in Humber and North Yorkshire. I just want to flag the York Multicultural Health Festival, the York Mela, that happened back in September. And again, a number of colleagues were here. A really innovative partnership piece of work, really focused on addressing inequalities in York. And I think it's the first of now, it's going to become an annual event. So there's more detail in the pack around that, but really, really innovative approach with partners. Yesterday, there was a regional event on primary care. Dr. Claire Fuller, who's the national lead for primary care and a GP herself, was there to talk to us about the Primary Care Access Recovery Plan, which again we've got a paper on, a detailed paper on, but we particularly focused on case studies around improvement, and I'm really pleased to say that Jason Atkinson, who's our local dental network chair, presented 2 case studies, one on supervised toothbrushing for children, where we've got that launching in 4 or 5 areas across Humber and North Yorkshire, particularly in deprived areas, because we know that improving oral health has such an impact on long-term health outcomes, and also on CVD prevention and screening with dental colleagues. So joining up the barriers between primary care, which is a key part of the work we're trying to do. And just need to mention the urgent and emergency care challenges that we are all aware of. We're seeing we've talked here before about how we plan across the system for winter, and that joined up plan. We're now in that delivery phase of winter, but we are seeing extraordinary pressure across the system. We're not unique in that in Humber and North Yorkshire, but we do seem to be experiencing greater pressure than others, and we'll get into that a bit more detail in the performance report. And we're balancing, I think, the here and now challenges around the operational pressure and also some of the financial pressure and the eye on the future. So we just to be mindful of that. And then lastly, just wanted to mention, obviously, the impact over the last few months on staff and on patients and on services in terms of industrial action. And just this morning, we've received a letter from Amanda Pritchard around financial support to address the significant financial challenges that have been created by the industrial action, and some immediate actions that ICBs with partner providers need to take. And across the system, we will just be working through that. It's just landed this morning. I just wanted to flag those things. Thank you.
Any questions for Amanda? Jonathan?
Yes, it's just a comment really around smoking cessation and health moving forward. I think there's a fear amongst the public health community that maybe because it's seen as a political initiative from the government, it doesn't carry the traction. It's really a plea to say it's not a political gimmick. This is something we really want to follow through, you know, irrespective of politics. And there was a request that maybe the board can, you know, say it is behind that move moving forward.
Yes, I mean, it isn't political.
No, it's not.
It's health related.
Yeah,
thank you. But good to raise it, Jonathan. You see, that's an example of seeing the world through different eyes, isn't it? Jonathan's world that we wouldn't have seen. Mark?
It was good to hear that Amanda Pritchard liked the Jean Bishop Centre, which does look really interesting. I guess my question would be, and I don't know whether it's to Amanda or other members of the team, what are we doing to build on the success, or what do we plan to do to build on the success of that centre?
Yeah, can I respond first, and then I would come to Andrew. But nobody could go to the Jean Bishop Centre and fail to be impressed by it, not just least the story of Jean Bishop and her legacy, but also Amanda had the opportunity to talk to patients and staff and really hear firsthand the impact that it has on people. What we know is that you couldn't take the entire centre and drop into other parts of Humber and North Yorkshire because they're all unique. We've got multiple different needs, buildings and services. But what we've created is the notion of a centre of excellence for integration around frailty. And the clinical leads, particularly Dan and Anna, who lead that work at the Jean Bishop Centre, and some of Andrew's team, are helping share that learning. So what principles can we take? What pathways can we use? What opportunities to integrate can we drop into other services? So there's already been some work accelerated in York, where they've launched a frailty model in York, and the other areas are following on from that. So, I mean, Andrew's really close to the detail, but we're absolutely exploiting it.
Do you want to say anything more, Andrew?
No, it's just, I mean, we're leading the process through the Community Health and Care Collaborative, and Erica Daly's picked up SRO on the behalf of the ICB and ourselves to try and work with partners supported by Yvonne from the collaborative as well. So, yeah, we're getting some pace behind it, and fits in with the work the collaborative are doing anyway around trying to spread best practice. So it's really great that the ICB is sort of like giving it some, you know, trying to create some status.
Good.
I absolutely agree with Amanda, and I think people get put off because it's a nice building, that you need a building and you don't.
Yeah.
I think there's something about culture, I think there's something about management changing its view on how these places are run and who people report to, and being a bit less protective about, you know, their bit. And I think that starts to shed a different light on how people can work together, especially if you place the patient at the centre, the person and the community, and then maybe sort of like utilise what you've got. So yeah, I think it's right. I think there's some good work going on. Don't let it be fooled that it's just there. There are some real great pockets of stuff that I think we can also learn from into areas where we've got some, you know, fairly good services as well. So it's a two-way process. But yeah, it's really getting some momentum now.
Yeah, it's a philosophy in action, actually, isn't it?
It's just a way of thinking and working.
Yeah,
so
Emma.
It is. Thanks, Chair. And I was going to say much of what Amanda and Andrew have said. It's absolutely not about a building. I was sort of with colleagues integral in launching the Jean Bishop Centre sort of back in 2018. But I think it's also an example of how you use workforce differently.
Yeah.
And it's not about additional workforce. It's not about additional buildings. It's about, you know, the model that we were talking, you know, the points Jason was raising. So yeah, very similar points.
No, and it's such an important point for us, actually.
Yeah.
Thank you.
Sorry,
Stuart.
sorry. Can I just say that one of the other things that I think about workforce is really important, because what we did make very explicit to Amanda was that when we were asked to sort of like work with the CCG and partners to deliver this, it was workforce was red, high red. Like, I mean, how are you going to get these people? In Hull, we have never been able to attract not one GP when there was GP with special interest. When I first came here as a young lad, there were we couldn't get anybody. I couldn't get anybody interested at all. Very few and far between. I think we've got 18 GPs now that are training in frail elderly care and things, and they're GPs, what were GPs with special interest. We've got consultants starting to come out into the community where they've been really about wards, changing their view on what this can do, seeing the benefits of upfront working. I think that the models, and I think that's what we need to grasp, is how exciting it is for practitioners.
Yes.
And portfolio careers are the way forward, so that for young medics and professionals, it's fantastic. They love it. So we never had a problem. I mean, we probably stole from other areas, but the point being is that actually, in doing so, I think it's starting to reduce workload elsewhere as well. Yeah. But I think the workforce thing is amazing, what you can get when you do something different, how people will come out of the woodwork and deliver.
And that's about creativity, isn't it?
Yes, yeah.
I have a feeling Stuart might be about to say something related but not the same, and Emma, you're just going to complete something. Is that right?
Yeah, that'd be great. Yeah, I was just going to say as well, in terms of the workforce, one of the things we need to learn is that Dan and Anna had to move employment in order to deliver the care within CHCP. And actually, if we, to deliver what we need to deliver, we need to have models that enable our workforce to work across organisational boundaries. And I think there's a huge amount of learning from that as an example, really.
And Jane's doing a lot of work on that at the moment, aren't you? We recognise it's a prerequisite. Stuart, then Simon.
I was going to refer to the IRIS launch yesterday. Very important work. What I'd like to hear about probably at another board is how we're going to keep on top of whether they're doing a great job or not, because it's so important that we both innovate and then spread out these good ideas through the improvement type processes that were being talked about yesterday, that I think as a board we need to be assured that they're having an impact, that things are really happening.
Yeah,
it's probably not for now, but I'd like to flag that as a future. And indeed, almost the same point. We're about to talk about population health in a moment. It's the same basic point there. We're going to spend, if we approve this, a decent sum of money, and I'd like to understand how we're going to get at the impact that we're having.
No, it's a really good point and a really good challenge, and so we should. Simon?
I was just going to add another comment about the Jean Bishop Centre principle. So I agree with everything that's been said, and said particularly around the workforce and how the creativity and different ways of working and the facilitation of that integration with little things like, for instance, whether you can access the internet in different buildings with a laptop, for example. I can't log on today, which is why it's special. But the issue about the building is a really important one. So I agree that we simply can't afford to build a Jean Bishop Centre in every community that would benefit from it. But there is a huge amount of underutilised or completely unused NHS estate that we are already paying for. And if you combine that with other sectors as well, including local authority and VCSE, there are ways in which we could create those spaces. And the principles, to follow what Amanda said, which is that we don't lift and shift the exact model, but the principles of it are absolutely right. And I know that Michelle and I, for example, as a Whitby GP, I've talked about Whitby Hospital being a great example of a fantastic resource that's underutilised. You've been in a chair, you've seen it as well. That's the sort of place where taking some of those principles and again using that to attract the workforce to a more creative solution than we previously got. And as long as that then impacts on reducing demand elsewhere in the system, which we know that this model does, it's a very attractive model for money that we're already using, not in a very effective way.
Yeah. Really a helpful conversation, and really great to feel that this board feels creative about these issues. I mean, we know there's no more money, don't we? We know we've got to use the resources that we've got more effectively, and we know what the challenges are we're seeking to tackle. And that felt like a very positive conversation to me. So thank you, Amanda. Thank you everyone. Item 10 is around population health and inequalities. I also thought this was a very good paper and a very straightforward paper. We were expecting Louise Wallace to be with us this morning. She's not very well today. So this is to Amanda. And in our discussion in preparation this morning, Amanda and I both caveat this paper by saying, if there's something that we don't know the answer to, allow us to get back to you with the answer. But there's a strong chance that we will know the answer, or we'll be able to phone a friend, but maybe not. So over to you, Amanda, item number 10.
Thank you. And hopefully it's quite a short paper and colleagues have had a chance to read it. Just a few things I want to pull out. A number of people around the table will remember that we had a really detailed presentation about the work of the Population Health and Prevention Executive Programme a few months ago. And this sort of is a bit of an update of where we've got to. Our joint forward plan outlines the commitments that we've got in this programme around the 6 work streams of the core 20+5 for adults and children, and then prevention, the public health side of it, the intelligence, and the building blocks for the partnership. And the Population Health and Prevention Exec is a committee of the board, so has got the ability to act in that way in the programme. The allocation specifically to the ICB for health inequalities is just over £6 million in the scheme of the overall budget of significantly more than that. And last year we focused on four key things. How do we support place partnerships to really accelerate some of the work they're doing? How do we invest and get upstream around tobacco control? And we know what we're doing on that. A focus on cardiovascular disease, and there's a number of aspects that we're doing around that, and then focus on healthy weight and the programmes around that. What's interesting is, rather than the 6 million, how we can collectively influence across the board, the ICS and our partner organisations and the wider partnership, other spend to think about how we focus on inequalities and population health. Just in terms of the two graphics in the paper, I think just want to pull out that the underlying cause of disease that impacts on health inequalities, the two biggest factors are those around diet and tobacco. And so actually, hence the focus on tobacco and supporting the Centre of Excellence, but also thinking about the wider determinants related to diet around cardiovascular disease monitoring and prevention. The 9 proposals all align to the strategy and the priorities and is a framework really as we move forward over the next few years. And again, a number of these things are either in train or focused particularly on where they are place-based priorities, particular focused. So they're all focusing on different things. Some are focusing on weight management, some are focusing on inclusion health, and there's a raft to look at. And I think that's all I really need to say. The proposals are fairly straightforward, laid out in the paper. The Population Health and Prevention Board approved all of these, and just to say that Stephen was part of that conversation before he went on leave.
Yes, so we're being asked to accept the 9 recommendations being made and approve the commitment to the Health and Equalities Resource as described. Charlie?
Absolutely approve, and the paper is fine. I'm slightly disturbed by a somewhat random 200 million being found and then allocated, and we get 6, and that's great, and it's welcome. But the paper says that we need to do much more. Yeah. And I wonder whether board and system can work towards allocating a greater proportion of the funding that goes through our various organisations to preventative action. The paper is really clear. This requires a long-term strategy. It's not a 3-year, it's not a 5-year, it's a much longer strategy. Yeah. So can we begin to explore the boundaries of our autonomy and see if we can allocate a greater proportion of what we spend than we do now, significantly greater, to preventative action?
Yeah, Amanda.
Yeah, and I think that's a really good point. And I think what is not laid out in this paper are the sums of money from partners that actually directly relate. And it's the bit about how are we agile as a system rather than wanting to control all the other bits of money, but make sure we align it in a way that has the biggest impact on the population health outcomes and reducing inequalities. So all of our public health colleagues in each of the 6 local authorities have a budget that's aligned to focus on prevention, inequalities, population health, public health. And similarly, the VCSE, we have opportunities and pieces of work that do that. And I think it refers in the paper that it's very difficult to capture all of that because some of the interventions around this are, very small at neighbourhood level that we may not even be cited on. So I suppose it's a drop in the ocean, but we're starting through the Population Health Executive with all the partners that we've got around that board table to really get underneath and understand the breadth of the work.
Absolutely. I think I've got a big queue now. I don't know where it started. Is it Jonathan and Stuart first? Then
Stuart was before me.
Maybe even Stan was before that then. So Stan, Stuart, Jonathan first. Okay. Then let's try again. Go on, Stan.
Okay, thank you. I really like this paper, and I like a lot about it, including the fact that all of the projects are linked to within our strategic objectives. Start well, live well, age well and die well. And I'm going to take this paper to our Cabinet, and I'm going to insist that our Health Scrutiny Panel take this paper. My observations about the weighting are very similar to yours, Charlie. But I'd also argue, and I'm sure you're not surprised by this, that when we look at health inequalities, we've got differences within the places within the region. Yeah. And I think, I'm not particularly making a case for North East linkage, I'll make the point, although I am actually. There are differences within the region that we do have to take into account, and that's differences in age expectancy, it's differences in disease prevalence, and, we've already talked about smoking and that sort of thing. So I think we have to, when we look at the allocations, okay, it's not the largest allocation known to man, but it's nevertheless significant. That we do try our best to ensure that we look at weightings in an appropriate and reasonable way.
Yes.
But other than that, I think it's a great paper.
Thank you. Stuart and then Jonathan.
So I enjoyed a visit with the tobacco control people. Was very impressed with what I heard. I'm slightly worried that we might be finding that they stop concentrating quite so hard on tobacco and try and do other things. So I'm wondering whether the Centre of Excellence model just needs thinking about it a bit. I like the fact that they wake up every day and worry about tobacco and its implications, and wouldn't want that dissipated.
Oh, okay.
So there's a sort of general comment. The other thing I think as a board it would be nice to hear is what we're doing against the key areas, the 6 major areas, possibly by rotation, so that we could understand what's going on across the system. So in tobacco, as they explained to me, they spend relatively small amounts of money, but there's all sorts of other things going on. And as a board, if we're going to make a difference, we need to understand all of it rather than just what Centre of Excellence type folks are up to.
Okay.
And my last comment is in private sector world, when you're trying to influence people to buy your product, and we're trying to influence people here to stop using tobacco, basically, you would have essentially marketing type feedback about your reach and whether people had clicked through on your website or whatever it was you were using to persuade. It'd be nice to see those kinds of reports specific to these areas coming back on whether we have or haven't reached people in the population who are smokers or who need to concentrate on their diet or whatever it might be.
For some of that, Anya, we'll have information. I said really confidently.
Yes, absolutely, Chair, and that a level of that information will be coming to the next board meeting. Yes.
Oh, okay. Jonathan.
Yes, thanks, Chair. I'm going to be totally parochial because having, I think, still the lowest funded public health department in the country has driven us, certainly in East Riding, to do lots of innovative things that aren't reliant on money. We had an excellent paper delivered yesterday on active communities, which touch on a whole range of the things you said, Chair. You know, there's lots of little projects.
Yes.
I think it would be really useful for this board or the ICP to maybe pull together what everybody's doing across the patch in these to get a real feel for some of the innovative work, because we were an exemplar about 10, 12 years ago in working with leisure services and everybody else, and I would love to volunteer to help pull together something we can present either to the board or to the ICP at some stage. I think it's really valuable insight into a lot of preventative work that's going on.
Lovely, thank you.
And I welcome Charlie's comments about extra funding going into this, because I think £1 spent there is well worth it, particularly for the next generation, maybe not ours.
Yeah, no, I agree. Now coming this way, but I won't forget you, Jason. Emma.
Thank you, Chair. Yeah, I've got a few points, and I think just first of all to say I have been working with Jack Lewis on some of this and committed to doing what I call a budget book on health inequalities. So I think some of what you've described there, you know, Jack and I have talked about, so really welcome other people's involvement in pulling the system-wide spend on health inequality and prevention agenda so that we've got visibility on it. And also that point about how we evaluate impact is going to be really important through that. The other point I was going to say is as well, it's how we link this to the overall prioritisation framework that we're developing, you know, that Amanda's leading through the operating framework for 24-25 and the medium term, how we link and have health inequalities as a golden thread through everything that, you know, the decision-making processes that we put in place on through that lens will be really important. And then just finally, a small point of principle. On the paper, there's a description of an uplift every year, and I think it's down as 5.09%.
Right.
That it's just to point out, we will go with whatever the national planning assumptions say. It will not be fixed. So when you're approving it, it's not approving a blanket 5.09% each year. It's dependent on what the planning assumption says. So I'll end on a less positive point. But sorry about
but an important one, Emma.
Sorry about that.
So then, Jane.
Thank you, Chair. It's just an obviously, you know, Charlie's point that this needs to be a progressive agenda which goes to the future is very welcome. It's an observation on how it's presented. So in Live Well, we're very clear about the groups of people that we wish to reach for health inequalities. Under Start Well, we're very clear about the conditions arising that we wish to target. And I wonder, as this work develops, if there's an opportunity to be clearer about within the core 20+5 group, who is it we are actually worried about? Is it children living in houses, you know, with families with multiple intergenerational unemployment? Is it poor housing? And starting to draw some of that out so we can start to have different conversations with our very significant providers of social housing, with Department for Work and Pensions, Levelling Up Partnerships. There's more people to feed into this. And I think it may be compelling to get just underneath it a little bit more around who is it in the, particularly the start well that we're concerned about.
Yeah, no, you're right. Jane, and then I'll come back to Mark, and then I'll move up the table. Jane?
Mine builds on that, I think, a little bit, in that I was going to say, don't forget about how important meaningful work is and the impact that that has on health inequalities. And I think if we have further conversations about this as a way to link some of the workforce into the health inequalities work, because it will have direct impacts. At the moment, it wouldn't be covered naturally in this paper, but will make a real difference to Live Well, for example.
Yeah.
And that work is happening with some traction at the minute. So just finding a way to link that.
Mark, then Michelle.
Thanks, Sue. Yeah, mine builds as well, but just to say, I think this is a really good paper, and I think Charlie's point about us putting the right level of support into this sort of thing is really important. And for me, I think there's something about the targeted interventions bit, which I can kind of see from a condition perspective. But one thing that got me sort of thinking through was at the Irish event yesterday, where someone stuck a Venn diagram, which wasn't about this. But what it did do is it showed where conditions, for example, would overlap. And I just wonder if there's a group of people out there that we know have got multiple conditions who are at the greatest risk if we focus really tightly. And I go back to Stuart's analogy, which is exactly what you would do in a commercial world with your most important customers, or however you want to look at it. Do we cut that way as well? I don't know who I would ask that question.
I expect everything's possible, Mark. And if we don't, I expect we can. I'm going to Michelle, then I'm going to Jason, who's had his hand up forever, and then Simon, and then Anya. But remember your own order, because I can't.
No, thank you. Great paper. Really liked it, and it's really good to be discussing this, and it's really good to hear the discussions that we're having, because I think it's obviously a key role for the board. I was going to obviously just reiterate about the wider determinants of health inequalities on the workforce piece, but one of the things that you would expect me to say that I think I've said several times around the table, which is around mental health and learning disability. People have even a worse record in relationship to health inequalities and die 10 to 15 years sooner than anybody else. So I think we just need to bear that in mind. I think the priorities are great, the paper's good, the principal, and I will make sure it goes to the various executives committees, but I just think we just need to bear that in mind about, do we need to put something in specifically, I'm not, maybe take it away, or just a thread in relationship to...
No, you're absolutely right, Michelle. And you're right, that's why you're here, to keep us on message.
Thank you.
Thank you. Jason.
So what I quite like about this paper is that longer term investment, that sense of, because we cannot do this overnight, so actually that sense of we've got a 5-year window to kind of really invest in something to make a difference. Because the problem with health inequalities is you can't do it in a year. So actually that sense of there's a tranche of money here, regardless of whether or not it's your 5% or not, Emma, there's a tranche of money, which means there can be sensible kind of decisions around what we decide to do. And I suppose for me there is, so I'm not going to object to the amount of money allocated to Hull, because clearly there's a benefit to being in Hull sometimes. But there is something for me about ensuring there's a consistency as to how Place makes decisions around how it's going to spend its money. Because I think when we did this last time round last year, there was a real variation in terms of how decisions were made about what to fund. So it's almost the bit around being clear around the expectations. It has to meet the kind of needs of Place. There's clear criteria in here, but what we do with the money is probably as important as what the money is. And actually, how do we do that creativity, that innovation? Because I think this is about creativity and innovation. This is about, it's all the stuff I think that was Anya's kind of paper from that LGBTQI kind of perspective is actually communities experiencing health inequalities need to recognise what we're doing with the money, and actually they need to recognise the difference. So how do we have a different conversation, kind of think and work differently around the public health kind of priorities? Because if we do what we've always done with this pot of money, we're going to be continuing to say these are things. So actually, how do we breed a whole creative dimension to what's going to make the biggest difference at Place? And perhaps some of that isn't what we do already. It could be new stuff that we do. And I think the VCS has got a massive role to play in some of this stuff. So we need to be part of those kind of conversations. I think just picking up what people say. So I struggle with health inequalities as a magnificent, well-resourced island. Because actually, in lots of ways, health inequalities is everything, isn't it? It should be the real thread that goes through everything that we do. And I think Jane's picked up the workforce piece. And actually, to answer some of that question around students, so a lot of people can't afford to study because actually they don't have any money. So actually, people can't afford. People are leaving in organisations around this table are choosing to leave work because they cannot afford to go to work. They cannot afford to drive from A to B in a car to kind of do their job. So there is something around how health inequalities becomes the challenge to everything that we do, because actually there's hidden resource that we're doing that actually is doing work around health inequalities, but we're not badging it because we've got a wonderfully well-resourced island. So this almost, that health inequalities test in every part of the work of the ICB is probably giving us different outcomes, but at the moment we're kind of holding them quite selfishly as being outcomes in different parts of the ICB. So I think there probably is additional money that's flowing through, but actually we're not saying this is health inequalities, but it's having that impact. And we need to change that thinking. So health inequalities, we don't get relieved seeing Jack's paper knowing something's being done. We all actually have a collective responsibility to do something with that. And I think workforce, the biggest single contribution we can make to people in Hull today, living in poverty, is to find them a job that's not 0 hours, that's not below minimum wage, because that will be the biggest thing that tackles everything else. That will get tobacco sorted. That will, get, kind of dodgy lifestyle choices sorted. Actually, it's workforce that will make the difference. So actually, we need to join it up to actually bring that about.
Yeah, really good point. Well made. Thank you, Jason. Simon, then Anya.
I'm obviously supportive of the paper. To some extent, Jason has stolen a bit of my thunder. One of the challenges around sort of incremental pots of money is understanding how they impact on the whole. And the only way, which I think is the point that Jason's making and others have made, is that we're going to make any kind of impact or difference around health inequalities is changing the way we spend the billions that we have, not the millions that we have. And so each of these areas that we are supporting today, I think, need to have a credible plan for how they are going to influence the behaviour of our health and care professionals across the piece as a whole. The other point I wanted to make is we shouldn't kid ourselves. Health inequalities are growing. They're getting worse. Yeah. They've been getting worse for some considerable time. As far as I can see, they'll continue to get worse because there are some smaller and bigger P issues at play in terms of socioeconomic conditions that we're dealing with. So I was going to make a bit of a proposal, really, that this is an area that jointly the ICP and the ICB should do some work together. And if there's ever a subject matter that we're looking for a joint session of the two, then health inequalities would be a good place to start, and to have that conversation about how we align our incremental investment on the supply side around health inequalities and prevention with the whole. And I don't just mean health expenditure there, I'm talking about the determinants of health, the kind of things that Peter was touching on in terms of looking at housing and looking at education, etc.
Yeah, thank you, Simon. Brilliant. Anya.
Thank you. Very much building on the comments of other colleagues, and it goes without saying again, fully support the paper. I guess it's fundamentally back to Pete's point around understanding and overlaying this with what are sort of some of those audiences that we're actually talking about and what we understand about those audiences, and also thinking about the modelling of what's going to happen with some of those groups in our population. And I was reminding myself of some of the insight that's been well published over the last week or so, particularly from the Joseph Rowntree Foundation, where it was saying now 1 in 20 people in the population, and I'm guessing to Stan's point, in some of our areas that will be higher, are now classed as destitute. And I think worryingly, it's not actually people that aren't in work. There's a growing number of people that aren't in work. And again, for those of us that were at the symposium, at the recent symposium, the young woman that spoke very eloquently couldn't have made the point more that her mother was incredibly hardworking, holding down multiple jobs. She was very bright, very well supported through the education sector, you know, had a roof over her head, but she was going to school every day hungry. And that wasn't to do with the fact that she didn't, you know, the family didn't have a job. It was the wider piece, and I think it's just crucial that we understand more about who these people or these communities are and what are the issues and what are their lives like, again, going back to the lived experience piece.
Thank you, Anya. Amanda. I didn't miss any. Oh, did I miss you?
No, it's all right.
Oh, Andrew. Okay, Andrew, and then Teresa, then Amanda, please. And then that is it. Go on.
Chosen, thank you. It was just to say that it's really interesting conversation as well, and a really great paper. I sometimes sort of like from being in population health management terms, There's a difference between the data and there's a difference between the thing. And a lot of what we're talking about is how do you actually take the data on a day-to-day basis and how do you allow professionals and practitioners that are working in these fields to do things in a different way than what they're contracted to do. Because quite frankly, the way that contracting is set, contracts and the way that key performance indicators do not look at this in any of the work that we do. The point of view being, if they did, we've got lots of people in everybody's house, we've got lots of people doing lots of things. Health visitors are inequality wellbeing practitioners. I've always said that. They don't like it, but being a health visitor, but they are. They're there. They should be focusing on the vulnerable. I'm extremely concerned in Hull alone about, and I've been around for a long, long time, and how much work we've done on domestic violence. I want to know exactly what our inequalities work is doing about some of the real in-your-face stuff at the moment that's affecting practitioners, families, children. And the proportion of young children in inner city areas that aren't sleeping on a bed at night or sleeping on floors with no covers is atrocious in this day and age. And there are charities out there that have been introducing to Hull and to other places to get kids a bed. The outcomes by just getting them a bed in the first years of their life to where they will be in Leeds is having major impacts on well-being. And I just think that we're missing a trick. We talk about start well. I think we're right. We need to be really focused on what are we going to do with the next generation to not get to the point where they've got multiple etiology problems, they've got multiple morbidity issues, and they're also dysfunctional, because the rate of homicide, domestic homicide in this country is going through the roof. And in deprived areas, it's really quite shocking at the moment to see. So I think we've got to keep our eye on it, and I think the devil sometimes is in keep focusing on things, but as you say, not evaluating them. And I wonder what the health economics, Charlie sort of like over there sort of like sparked me on this one yesterday about the health economic benefits of investing this money in what will get the biggest impact. And I think we've got a duty as health to use as much money as we can to influence the health positive outcomes that we've got control on whilst working in partnership. And I think sometimes that gets blurred. So where exactly are we going to get the best so that we can manage our access and demand? And that's not saying that we're not going to be able to do everything, and you never will in management terms, but you can really sort of like make some big impacts. Secondary prevention that's in here, but I think we're going to miss a trick with young people at the moment and family dysfunction, which is causing major problems.
That's a really strong contribution, thank you. Teresa.
Well, thank you. The focus on the next generation was the bit that I wanted to tease out, and in particular, as Jane's alluded to, obviously, that in terms of living well, the biggest thing we can do is get people into employment. In terms of start well and improving life chances for children, it's education. And, you know, we've got some really stark data around school absences since COVID. So I absolutely support Simon's view that this should be an ICP, and we need to tease out those elements and focus on those areas within each of our domains that actually will give us the biggest return in the longer term.
Yeah, thank you. Charlie, just to complete that circle.
Perhaps to close the circle, Teresa and Andrew, the Futures Group is beavering away at the moment, and if all goes well, we'll be bringing some proposals, I think, to this board in February, precisely on the kinds of things that can be done around early years early children and young people interventions. So I think we'll have more to say about that on a more informed basis through that work in a couple of months' time.
Thanks, Charlie. Amanda.
Thank you. So just three things. Firstly, around one of the key parts of this is that we've enabled and supported local places to pick the priority areas that the data shows are most impactful for their population, and it's varied across the six. I think that would, picking up Jonathan's point around some work with the ICP, be really good to showcase that, the impact of those different things, and then how we share quickly that good practice so we don't duplicate. And Hull, as an example, have picked domestic violence as one of their priorities. The second thing is just a shameless plea on behalf of primary care contractor groups. GPs, dentists, optometrists and pharmacists have a massive impact at the front line of health improvement and early detection of ill health and health inequalities. And just the example around supervised toothbrushing and the pilot that we're doing, not funded, not referenced in this paper, but actually will have a significant impact over sort of 5 to 10 years in terms of improving health outcomes for young people. And, you know, 25 to 29% of children across Yorkshire and Humber have significant issues with oral health. And then lastly, there's just a very small amount of money outlined in here around seed funding. And again, this comes back, the link to Iris around innovation. It might be a tiny idea that needs a small amount of money that grows into something that is really impactful. So I think that, again, around the innovation approach is really useful. Thank you.
Thank you, Amanda. And thank you all very much indeed for your contributions. You know, what's really powerful for us is we've got it, haven't we? We get it. We get that to improve our system and to improve the health of our population and to reduce health inequality requires us to work differently. There's no doubt that we've all got that now. And you know, when we first came together a year or so ago, 15 months ago, I don't think we felt it in the same way as we do now. That is fantastic progress. And the other thing that I feel that is a real plus for this board is, you know, we've talked about the symposium where we sought to reach a wide group of people to talk about the Child of the North report. We had our Iris launch yesterday, another futures type activity, where we sought to speak to a large group of people about the ways in which we can innovate and move forward. And the Futures Group, which collects up a very interesting group of people. So as well as all the here and now stuff, which we're about to get seriously into, what's powerful for our integrated care system, for our partnership, is we're also carving out time to have conversations about the future too. The things we need to do to move forward, the strategic things we need to do, not just the things that appear today as precious today. That's very powerful and it's very important. And I think the conversation that we've just had shows that we're trying very hard to maintain that balance. And I'm grateful to all of you. So thank you for that. Let me just give you a little time check now. So it's 1 o'clock and we're really on time. We're going to look at quality issues, the clinical and professional paper and the primary care recovery plan. Those have come together as a piece for the board. So we've got 45 minutes looking at those 3 papers. And then just so you know, you get a coffee break. That's what I was really getting to. So it's a slightly unconventional timing that we're running. So 45 minutes through these papers, please. And then coffee at 1:45. In that case, it's directly to you, please, Teresa.
Thank you, Chair. There's 3 things I want to cover on this report. The first is the patient-led assessments of the care environment. Obviously, the slides were included. I'm not going to go through them, but if you could go to slide 4, so that could be up whilst we're just talking. That's the one. So, a bit of background. So, the place assessments, not to be confused with our places in terms of the ICB. So, pre-COVID, these were assessments of the care environment that were done on an annual basis. And they are undertaken by teams of staff made up of and including members of the public, and they're known as patient assessors. So, the assessments have been running for quite a few years, but the domains and the standards were revisited and revised in 2019. And then, of course, COVID hit. So that's a long way of saying we can't compare these results to any results that we have had previously, so because they have to stand alone. So what you've got there is just an assessment of our providers against each other in terms of the lowest and the highest scores across all of the domains. So York and Scarborough have the lowest across 5 domains. I think in fairness that reflects the findings of the CQC report in 2022, because that's when this is from, and against which I think there's been significant improvement. So I'll look to Simon to give us a degree of optimism in terms of how that's going to play out in the next round of assessments.
Nodding.
It will. Okay, excellent. So Harrogate have the lowest score across 2 domains and Humber just 1. Could you just go to slide 6 now, please? So because obviously they were just being, you know, highest and lowest against providers within the ICB, we need to tease out the fact that where we've got the highest scores for Humber and North Yorkshire, they were better than the national average scores across all those domains. But equally, where there were the lowest scores, they were below the national average. And in terms of York and Scarborough and Humber, around the condition, appearance and maintenance of buildings, they were below the national average as well. So obviously we had a detailed IPC report last meeting, and we take forward these results to make sure that any actions required from an infection prevention and control perspective are actually picked up. So that's all I wanted to say on the place assessments. Unless there's any questions on that, I will move on to the Quality Committee.
One of the things that is important for me about the place assessments is it's another way of seeing what we do through the eyes of those we serve. It's the way others see us and perceive the organisations that we're running. So really important from that perspective, I suspect. The other thing that I think we're going to find increasingly organisationally is this is telling us what's happening in NHS provider trusts. It isn't telling us what's happening in any of the other settings for which we're responsible and about which we also care deeply. So this really is just a shot of one particular part of our responsibilities.
I would add yet to that statement,
yes,
because obviously that's something that we are looking at. So moving on to the Quality Committee, I'm assuming that most people have read the paper, which relates to the Quality Committee that was on the 31st of August. So there's just a couple of things I want to particularly tease out of this. So the first is the detailed paper on maternity, and we had that then at the following private board because of some of our risks around the maternity services. So obviously at the Quality Committee we discussed in depth those key risks, the actions that we were taking, and then the additional action that we have subsequently acted upon, which was around the maternity collaborative programme, and we'll be launching that shortly. We've had the first meeting with Aqua, so we'll be launching that in the coming weeks. The second area to note is the progress on the PSURF implementation, and specifically the delegated authority to a PSURF implementation group, and we agreed the terms of reference for that group at the committee. The third area to note is around the domestic abuse and sexual violence statutory responsibilities, and what we do at the Quality Committee is we have a rolling programme of deep dives into our statutory responsibilities. That's what we did with domestic abuse and sexual violence, and then subsequently, of course, we had discussion at the board around that. And the final area to note is around the SEND work programme. So there were a lot of papers, and it was a really comprehensive agenda item because this area of responsibility is increasing all the time with changing national guidance, and really important that we work really closely with our local authority colleagues on the SEND agenda. And on that note, just to say that there is currently, as of this week, a joint CQC and Ofsted SEND inspection in Hull. So that's all I wanted to tease out of the Quality Committee to specifically mention.
Any questions for Teresa in respect to the Quality Committee? Thank you.
And the final thing then is on the System Quality Group. So just a reminder that this is a key part of our quality assurance and improvement arrangements where all stakeholders come together to, excuse me, to triangulate soft and hard intelligence to identify and discuss what we believe are the key risks to quality and safety across the system. It won't come as any surprise to you, the items that are identified as a summary in the summary as the key risks. We've discussed them at the board before, but obviously we start with UEC. We also, that's the urgent emergency care issues, not only the ambulance delays, but also issues that have been raised around discharge. The second area is on the maternity, which we've already talked about. Sorry, I'm just taking forever to get down my slides. The paper's too long, that's what I would say. So sorry about that. I can't find the page, I'm sorry to get my... Here we are, okay. So, urgent emergency care, yeah. The increasing 12-hour trolley waits, which you will see in the performance report as well, and what we're looking for in terms of assurance really about is how those patients are managed whilst they're waiting for such a long period of time. You know, are they hydrated, are they fed, pressure area care, etc. The third area we identified was those range of clinical indicators of harm across all providers, such as IPC, falls, pressure ulcers, etc. And we're picking up one of those areas again through a collaborative programme supported by Aqua. The next is around elective weights, and in particular a focus. We had a discussion about patients with a learning disability and getting assurance around them being proactively managed whilst on the waiting list. And the final area was around learning disability and autism services, concerns regarding capacity within existing services and access to the full range of services locally that we would want to see. So that's all I would summarise in relation to those.
Thank you, Teresa. Any questions for Teresa? Nothing further on quality? Okay. Let's move on. I think you're also picking up Nigel's paper, aren't you, Teresa?
I am indeed, yes. That's a good reminder. Let me grab. Thank you. So, in the clinical and professional group paper, which I will hopefully get to the beginning. So again, I'm assuming that people have read this, so there's just a couple of things I want to tease out. The first, Nigel discussed at the private board last time around the work on procedures of low clinical value. And I just want to tease out the follow-up discussions that we've had, particularly around hyaluronic acid, of which we, all CCGs formerly had a no commission policy in relation to that, but we still spent £1.7 million on that as a procedure last year. Subsequent to the last board meeting, a further quality committee has reviewed all the information around that and has approved a ICB policy of our stance of no commission position. And then there was discussion about the work that we're going to do to communicate that and ensure that we don't actually spend that money on that procedure for which there's no evidence base. The second area is around the work...
Is there any indication of time on that, Teresa? Do you happen to know? So how long are we going to think about it before we just say it?
No. So the policy was approved. So our position now is we do not commission it.
Okay.
So it's then enacting that and making sure that those that are undertaking the procedure are actually aware of the fact that we will not pay for it.
Okay. Emma.
Yeah, if I can, Chair, just to come in on there as well, because I would like to connect it back to the conversation about the health inequalities as well, because I think what this does is then give us the resources and money, capacity, workforce to direct towards health inequality.
Absolutely, because our duty is also around the opportunity costs. So if we're spending things on things of low clinical value, we can't be spending them on other things.
That's the case for our 3.7 billion. Jane.
So I think when we talked about this last time, I probably raised the same point I'm about to raise, which is it might have limited clinical evidence, but there's the psychological impact of people that think that that treatment is actually going to help them, and how do we tackle that or deal with that rather than just withdrawing something?
Yeah, we did discuss that as well at the Quality Committee, and a lot of this comes down to how you actually then communicate this to patients, and there was a discussion and arrangements for that. Because there is no clinical evidence, as you say, it's a placebo effect.
Yeah.
Something's happening, so I must feel better. And whilst we've got to take it into account, clearly we cannot continue to spend money on placebo activities.
Absolutely.
The next areas around I think is worthy of attention is the clinical effectiveness work, which the scale of that. So each of the 6 places have been asked to review 10 policies, so that would be 60 policies in total. And there are clear indications for those policies that are going to be reviewed. So those that are subject to the most independent funding, individual funding requests, and or changing guidance, such as NICE, if they've revisited their position. And we've had one recently in terms of caesarean section. So we're revisiting policies around those sorts of things. And the third area is the interface groups. We have 6 interface groups, and these are groups that interface, as they say, between primary and secondary care. And although the 6 groups, that shouldn't be assumed that they're on our place geographies. They're not. They're reflective of patient flow from secondary providers and GP practices. So, excuse me, 4 areas of focus, which is driven nationally, but equally those are important locally. And I think we had a discussion at the clinical and professional group about the work of the interface groups and the read across to the primary care recovery plan, and supporting both of those working together. So that's all I wanted to say, and I will take your premise, your caveat that you gave earlier, that if anybody asks any difficult questions and Nigel's not here, I will refer to phone a friend and a future follow-up.
So Simon, Mark, then Jason.
I was just going to add a bit more information about the interface work, partly because actually in the primary care paper it is in the appendices, but actually I just thought if I mention it now it's probably more relevant, plus it also buys me more time for the primary care bit. The link between the two is quite simple. That work that there has been, for as long as I've been a GP, there has been not because I've been a GP, but there's been this complaint about unfunded work that gets passed from secondary care providers to primary care to mop stuff up. And this is about trying to just redress some of that balance so the most appropriate people do it at the first time rather than patients being sent on a wild goose chase. You know, patients been in hospital, they've been discharged, they need a sick note so they can't go back to work yet because of their broken leg. Go and see your GP to get the sick note, when in fact it's the hospital who can sign them off quite clearly. So this is about some of the really simple nuts and bolts, practical solutions that will reduce unnecessary demand on primary care, which will help us meet the capacity demands that are currently part of the restrictions around access within primary care. And those key priorities are fit notes from secondary care providers, call and recall systems for follow-up. So instead of writing to the GP saying, I've started this new medication, please will you take a load of blood in a month's time and check that it's all right? Actually, the hospital can put those arrangements in place, not least because the blood samples go in a van back to the hospital for testing anyway. And instead of me then getting the results that I have to then send to the consultant to say, the medication you started has had this effect, what do you want me to do about it? It cuts out the middleman, if effectively, of the GP. There is an issue sometimes, particularly in rural areas, about not having the patient having to travel back to the hospital, but that's about community outreach from secondary care providers to provide services for patients in places where they live, rather than the default position of sending them back to the GP. There's also the issue about cutting down on improving self-referrals. So, you know, the old-fashioned thing of go and see your GP who'll do you a referral to get a walking stick from the physio. is just bonkers, and that's going, and there is some evidence in the paper about where community services in particular have started to improve their access to self-referrals. And the third thing is around liaison with patients and with professionals between hospitals. So having easy points of contact, single points of contact. So, for example, patients who constantly ring us and come to see us about when am I going to have my appointment with the orthopaedic surgeon at the hospital, actually being able to ring the hospital directly and find that information rather than coming to see me, who asks my secretary, who rings the hospital, and then I have to ring the patient back again. So it's just simply putting in place some of the things that occur at that primary-secondary care interface. This has been going on for at least 25 years, but there is now, I think, a much stronger national push to get some of this right, and that's what's documented in the appendix of the second paper.
Thank you. Very enlightening. Mark?
Thanks, Sue. Yeah, going back to the paper, Teresa, so you might want to deal with this appropriately. It mentions high-cost medical retinal vascular medicines.
Yes.
And I know that the high cost of those is a big issue to some acute trusts in particular. And the question is it a great investment or is it not? So I think that's really important to know. Do we know when that piece of work with medicines management will take place? Because my understanding is that could be quite a large cost impact if the decision is that we don't need to spend as much as we do.
So Nigel will cover that in the next board meeting. It is very complex. We have gone further down the line in terms of making a decision on that, and it's referred to in the, or will be referred to in the Quality Committee update from the next Quality Committee. So there is a decision on that too.
Okay.
But Nigel will take the board through it because it's very complicated and not without some areas that we need to watch carefully.
Okay, thank you. Jason, did you have your hand up?
Yes, I did. And it's just going back to the clinical effectiveness and the 10 priority interventions. And I think there is something about an assurance around impact assessment. So I think we touched on this at the Quality Committee, where I think what's really important is that those impact assessments talk around the impact on specific populations in terms of decisions we might make to change things or stop things. So it's really important that they're filled out wisely and well, because if they're done properly, they help us manage risk, but also talk to us about where the engagement needs to happen. So actually, where is the biggest impact going to be? I think at the moment, and I know we're moving to a new system, there is, from my point of view, having looked at the ones that went through the Quality Committee, a massive variability between ones that are completed really well, understand the difference between negative impact and positive impact, and ones which either hadn't been completed or were completed less well. And I just kind of think, I know it's early days, but we have to really be belt and braces on this type of stuff, because this is the stuff that's open for challenge. This is the bit where people can come back and go, hang on a minute, you haven't had a conversation with me. It's Jane's point around, regardless of whether or not the injection works, the perception it does means that there has to be a conversation that talks about this is why we're making the decision. It's almost the bit, and it kind of flows through, because I noticed we've got some different formatted impact assessments later on in the agenda to the ones that we kind of saw with some of the policies. So I suppose my worry is, unless we get really, really smart doing proper, meaningful, well-written impact assessments, we create a massive amount of risk. And having spent a lot of my CCG life, as Emma remembers, on impact assessments, the other bit is almost getting that consistency around what we should be articulating in an impact assessment is an understanding of our population. So we should be understanding what the makeup of the population is, where the impact might fall. Actually, the fact we don't have a consistent narrative that we can just reproduce that says this is our population really worries me. So I know I raised it in the Quality Board, and I apologise for raising it again, Teresa, but there is just something around that has to be a today, not a tomorrow.
So just to be, absolutely agree, just before I come on that point, just to be clear, that was a subsequent Quality Committee, not the one I'm repeating. Yeah, absolutely. So you obviously it's happened too recently.
You'll find that
for the
next
update
time
for the board.
Yeah.
So that will be discussed. So as Jason said, there was a lot of discussion about these because, as you say, some came with no impact assessments, and others. I don't think there was a particularly good one that we could have teased out and said everybody needs to follow this, if we're honest. So I think we do need to give some thought to, I think there needs to be training across the board around how to actually do this and do this well with, as you say, the population information that you're actually using as a starting point. Because at the moment it's a bit like this is another piece of paper that you've got to fill in alongside the policy template, as opposed to a real understanding of what it is that you're completing and why you're completing it. And the fact that really we had to play out, the discussion played out those quality impact assessments because they were absent. So it was beholden on the quality committee to do that. But we need to get much better at that.
Okay, thank you. Busha.
I wanted to just add about the interface. Simon's sold it as being really, really good for primary care. I wanted to point out that secondary care organisations have a contractual obligation to work at their interface, and they have to provide evidence about the work that they have done at their interface. These interface groups are very beneficial to secondary care organisations. Primary care does not have that obligation, and when we're asking primary care to work in these groups, in these meetings, and provide those solutions and new ways of working, we are doing that, asking them to give their own free time. And we do really have to think about how we can facilitate attendance and actually injecting some cash.
Thank you. Okay, let's make a note of that. Thank you. Let's move on to item 13. This is to Amanda, to Simon, to you together.
So I'll just start, and then I'll hand over to my expert colleague at the end of the table. I'm really pleased to bring this Access Recovery Plan update. It was May when it was launched, and we were in York, and it literally was launched on the morning of the board, and we talked about it collectively in terms of the challenge that we know some of our patients have in terms of accessing primary care, particularly getting through on the telephone. And this Access Recovery Plan, through some investment, addresses one of those key issues in terms of digital infrastructure. So, and I'm also glad that you thought that it was helpfully laid out in terms of the journey that it goes through. So there's 4 priorities. We address that in terms of the progress against it. There's, I think, 3 themes just to pull out. One is the importance of workforce. There's a theme in the board conversation today, but we pull that out, particularly in relation to some of the challenges in Hull that we're facing and some of the opportunities to improve the workforce, both GP and the wider primary care team. The fact that this, again, is a strategic approach, but it's locally responsive, so our geography is huge, our practices are unique, and our populations are different. So each of the solutions that the 6 places are leading on are slightly different in response to the need. And then the digital theme in this, so moving from analogue phone lines to digital infrastructure, and I think 48 of our practices are in that camp, and also the reference to the NHS app. So we're ahead of the curve in terms of utilisation of the NHS app, which is really easy to download, and actually once you get shown how to use it, really easy to order repeat prescriptions, book appointments, and talk to your practice, which means that we're not having patients waiting on the phone around that. So the other thing, just to reference, is that Simon and I were both at the session, the primary care regional session yesterday and Claire Fuller spoke, and she referenced the Access Recovery Plan and the explicit requirement for the paper in terms of update to come through boards, and she said there's an expectation it includes reference to the work on the primary and secondary care interface, which ours clearly does in some detail in the appendix. So I'll hand over to Simon to get into some of the detail.
Thanks, Amanda.
Thank you.
Thanks, Amanda. So the purpose of the paper is to provide the board with the opportunity to be assured about our progress against the National Recovering Access to Primary Care Plan. So the paper attempts to do that. I'll just pick out a few highlights and then very happy to take your questions as further scrutiny as well. Just to be clear, this is effectively a wording error from NHS England. This is not a primary care access recovery plan. It's a general practice one. So I won't be taking questions about dentistry, optometry or community pharmacy today. There will be further opportunities during the course of the year for our fellow independent contractors for that. There is no current national dental recovery plan. There needs to be one. It keeps being promised and it keeps being the can keeps being kicked down the road. So we don't know yet when that will come or if it will come, certainly this side of a general election. So this is just about general practice today. So I guess in terms of assurance, I'm going to do it in two halves. The first half will be just to let you know what we are doing and where we're achieving targets and how that's been done in brief. And the second thing is to point out the areas where we know there's still significant work to do and to assure you about the work that we're doing to meet those areas that we're not meeting. So in the first bit, I guess the first headline is that there are two requirements within the Primary Care Access Recovery Plan. There are two specific measurable targets, albeit there are two aims, both of which are more difficult to manage. So the two aims that are difficult to measure are tackling the 8 a.m. rush. I can't get the lived experience that we know patients have. We probably have them when we're patients as well, which is that you try to get through to your doctor's surgery at 8 o'clock on a Monday morning and you're either held in a queue or you can't get through, and if you do get through, you're told there are no appointments. Just to be clear, that isn't universal. It definitely happens, but I can tell you now, my practice has never said, you've got to ring back, we're full. It's frustrating at times for me as a clinician that at 29 minutes past 6 I can still get a request for appointment that is granted by our receptionists, but they do, and lots of practices are in that position, but we know that that is not universal, and our plan is that we need to make that universal. We were the only ICB in the country that committed to its share of the 50 million extra appointments in general practice, and we are on track to achieve that by the end of the year. We're on track now, we're achieving it, but our belief is that we will continue to achieve it. So this is not an aspirational plan. We are on track to hit 10.5 million appointments in total in primary care in this current financial year, and that's a 4.7% increase in the number of appointments compared to the same period of last year. Just to put that in context, 10.5 million appointments is an average of 6.2 appointments in general practice for every single patient registered in our ICB. When I started as a GP 25 years ago, we were taught that on average, patients attended their GP 3.5 times per year, and that's what the funding has been set at. And the funding throughout the last 25 years, as a percentage of overall NHS spend, has continued to remain at between 8 and 9%. It did reach a peak of over 10% a few years ago, but that is now really quite a few years ago. But it is back down to 8 or 9% of the total NHS pie is spent on general practice, where we see over 90% of all contacts of people that are seen in the NHS today. So we are on track to meet our commitment across the ICB to increasing the capacity of appointments and therefore improve access and the experience for patients. The more detailed table does show that in one of our 6 places we are under plan, and that is in the city of Hull. And so we are aware that there is additional work that we are doing around that to make sure that all 6 of our places are achieving plan, as well as us overall. The other area was around the timeliness of appointments, and that relates to this arbitrary figure that's been chosen of all patients should be seen within 2 weeks of requesting an appointment. Of course they should. Just to be clear, at the moment, NHS England is unable to measure that. It's only able to measure the time between an appointment being booked and the date of that appointment. So there's a difference between an appointment that's booked because a patient rings up and says, I don't feel very well, I'd like to see a doctor, can I have an appointment? And it's given in 3 weeks' time, the first available appointment. That's bad. Patient sitting in front of me who I start, say, an antidepressant or an antihypertensive medication, and I say to them, I'd like to see you in 4 weeks' time so I can check that this medication is working. If I book that appointment with that person there and then, I breach the target. So what has been happening until fairly recently is people have been saying, I'd like to see you in 4 weeks, but can you ring back to book that appointment? But don't ring back in the next 2 weeks. You've got to ring back in the 2 weeks after that so that we hit the target. It's bonkers, and it's exactly the sort of behaviours that we know these arbitrary targets can change. There is now the ability to exception report those types of appointments where it's the patient's request or clinical indication for it to be longer than 2 weeks, but as yet the data as extracted by NHS England does not represent those exceptions. It does not include those exceptions. as in it includes them, it doesn't exclude them, which it should do. So we're currently achieving 82% against the target of 85%. However, it includes all of those appointments where it's entirely appropriate or the patient's choice for it to be longer than 2 weeks, because at the moment there's no way of the data being manipulated in a way that allows it to be a more accurate reflection of what the target is actually trying to achieve. So it's just an important proviso. The exceptions that are now being put in by practices when they're booking appointments and NHS England working out how to represent that in the data, I am confident will lead to us being able to significantly achieve that 85% target across all areas within this financial year, but it's just a data quality issue currently at the moment. What's the key issue that we haven't, Amanda's mentioned it already, and that is that access is all about capacity. This is not about doctors sitting in their office, twiddling their thumbs, just being awkward and not seeing patients for the sake of it. This is about capacity, and we know that the numbers of GPs are significantly short of what's been projected by both the profession through the Royal College and the BMA and others, and also that the government have accepted. The number of GPs in training is increasing, but the number of GPs leaving and the number of GPs reducing to more part-time working is currently still, it's 5 or 6 years down the line from the initial plan, is still exceeding the growth in the number of new GPs. So the headcount is slowly going up, but the total number of full-time equivalents is still going down. We are managing to turn that round, and one of the few areas that's seen an increase in GPs locally, an increase of 4.7% is in Hull. So again, that issue about Hull having at the moment the lowest capacity of all of our places, and therefore the most difficult access. There is potentially some light at the end of the tunnel with the improvement in recruitment in Hull. Two other areas that I'll mention just in brief then are this concept of modern general practice, the digitalisation of the experience with general practice. Cloud-based telephony is important. It allows better data about how many calls a practice, for instance, is receiving, when they're coming in. It allows real-time management of that. I'll give you a little example. In my practice the other day, we were talking about changing the day that the clinical team meeting is. That would normally be decided on which doctors and nurses and others are available. The practice manager said, I want us to decide it on the basis of when we have the fewest numbers of requests for appointments. Let's look at our phone data, our telephony data, and work out from there where is the dip in the week when we can actually have our meeting, so it doesn't interfere with clinical service delivery, rather than when are you lot available. And that's the sort of thing, a tiny example, it's the sort of thing that we're now much more able to do. It also involves giving options, shouldn't be imposed, but options for patients to use alternative routes rather than the telephone to access advice. And we know that in some circumstances, particularly at the more urgent and transactional end of general practice, that is a more suitable use of resource for some people, but it also should never replace the face-to-face and the relational continuity of care long-term with people who know you, which is the ambition, which is why most of us became GPs in the first place. What are we doing around workforce, and in particular about the inability to recruit GPs, but the ability to recruit others? We've, over the last 4.5 years of the additional roles reimbursement scheme in general practice across Humber and North Yorkshire, we've recruited 924 whole-time equivalent other practitioners delivering frontline direct patient care. And the majority of those are clinical pharmacists, care coordinators and social prescribing link workers, followed then by physiotherapists, first contact mental health practitioners and others. Just to put that in scale, that is approximately 13% of the total spend in general practice as an increase, so it's a not insignificant sum, and 924 whole-time equivalent non-doctor clinicians working versus what we currently have in place, which is 1,079 whole-time equivalent GPs. So it's not insignificant, but it doesn't address some of the lived experience that's in the paper, which is that people want to see their doctor, and they want to see them. Actually, 70% of all of our appointments are still face-to-face. and they want to see their doctor, they don't want to see a care coordinator, a pharmacist or a nurse practitioner, that is a bigger challenge, because actually the recruitment where we are being successful is in those roles, not in doctor roles. And I'm pleased to say that finally NHS England is launching at the moment, which we're taking part of, a significant major national public campaign around talking about the general practice team rather than talking about the general practitioner, which I think may go some way to helping match what we're able to supply with what patients expect to receive when they phone up. The only other bit I would say then, in terms of, so we're aware of the areas that we are where we're achieving. We're aware of where there's work to do, and in particular there was an operational primary care meeting this morning, for instance, where this primary care leads from all of the 6 places were sharing the examples of where they are achieving against these targets, and sharing the ways in which they're doing that, which can then be tried by those other areas. An example of which, for instance, would be using things like AccuRx, which is a new integrated software system that we can use with our GP systems, that allows us to send out text messages to patients inviting them for instance, their preventative chronic disease management review appointments, where they then, what used to happen, we used to write to them and ask them to phone us and book an appointment. What we now do is send them a text that's got a link, and they can directly book their appointment at a time of their choosing. And what that is doing is twofold: reducing the number of telephone calls blocking lines into GP surgeries, and secondly, it's reducing the DNA rate at long-term condition management appointments, because patients are choosing their appointment and they've got electronic reminders of when they are and things, rather than the more old-fashioned analogue systems of letters and telephone calls. So those sorts of examples free up capacity, and it's those sorts of implementation of those sorts of schemes that are being shared. And in particular, for instance, there was a discussion this morning that I was updated on earlier that relates specifically to increasing capacity within Hull for that sort of example. Just the final thing I'll say on patient experience, and it was in the paper, but it is worth saying, and this is in no way to negate the lived experience examples that are also given in the paper, is in the National GP Patient Survey, published every year, conducted independently by Mori, general practice in our ICB scored above the England average in every single indicator. Wow. So whilst things maybe are not as good as we want them to be, we can at least be assured that we are in the upper half of patient experience, and we need to continue to do that and make sure that that is a consistent offer, a consistent experience that patients have with regard to their access and their experience. But that requires us to ensure that the capacity is in place so that we can continue to do that in a way that is sustainable. I'll pause there, happy to take any questions.
Thank you so much, Simon. Michael, yes, you.
Thank you.
Please.
I found this really interesting. One observation, particularly around supporting high-intensity use of patients, is clearly a factor, but also those people who might only contact their GP practice once in a blue moon. You still want those to use the right routine, and they're probably more difficult because they have so infrequent contact to know what's the modern way to contact your doctor's surgery. But one plea really, which would be to challenge the practices to see what their preferred interaction route is with the social care professionals who might need to speak to the practice. Because I get the impression, and it's not backed up by evidence, so I'm happy to be challenged if that's not the case, that we may find that you've got social workers and social care coordinators stuck in that queue of telephone trying to get through because they don't have another route in. And that's probably not the right approach. It's definitely not the right approach for them, but it's probably not the right approach for the practices as well. So if I could just ask that that's borne in mind in this piece of work, because if they don't have a special route in, they're just another call.
That was a special bit of common sense, thank you. Appreciated. First of all, Charlie, then Anya.
Thank you. I think this is brilliant, and I think the use of technology to strip out some of these inefficiencies in the system is superb. I the GP service I get in York, I think is great. I think COVID has just driven it on into a place where it wasn't. And I'm really, really comfortable with using the digital interfaces. I recognise that a lot of people aren't, though, and I recognise the frustrations that are felt. But I'm wondering how much that impacts on the welfare of those who work in GP practices. And you probably were aware that about a month ago, a GP, and disclosure from the practice group I'm in, wrote an open letter saying, stop the death threats, basically, and all the intimidation and the violent language and so on. Is that just an isolated thing, or is this a general problem for those working in practices that emanates from the frustrations that some people feel?
Do you want to answer?
Yes, please.
To the two issues. So I'll do Charlie's issue first, then come back to Mike. So you're absolutely right. Certainly one of the experiences of staff with regards to some of the implementation of the more modern general practice digital solutions is that people have just got far easier routes to contact them than they had before, and they are therefore more likely to get swamped by demand. One of the examples that's given, which is a good thing for patients and the public, which is that you can fill out an online triage type form any time of the day or night. It's more convenient. You don't have to sit in a queue and then you get an answer in 24, 48 hours or whatever. One of the experiences for lots of doctors is you're going in on a Monday morning, and you were always prepared for Monday morning to be busy, but you're going on a Monday morning and you've already got 100 tasks sitting in your inbox that have come in over the weekend. And where do you start with that? So there's something about how you implement those solutions and the whole business process re-engineering. It might be if we really want 7-day general practice, we need to work out how we get to that. Very difficult to have 7-day general practice when you've got an ever-shrinking workforce, because all you're doing is spreading everybody even more thinly. But it may well be that we need to, and again, it's about managing expectation. And one of the issues around some of the issues around, and you'll all be aware of the incident that happened at Ampleforth practice, a less likely place to have a violent patient incident is not possible to imagine. The issue there, I think, sometimes is that the language that is used, including by NHS professionals, but certainly by politicians as well, can be deeply unhelpful. So if somebody's on, if you're one of the 7 million people on a waiting list for a hospital appointment, it's not the consultant's fault. It's the system's fault. It's COVID. It's all sorts of things. If you can't get an appointment with your GP, the perception is it's your GP's fault personally. And if they live in your town or your village, or they're frankly leaving the surgery at 9 o'clock at night into a darkly, dimly lit car park, actually that is a more threatening thing. And we have recently, even in our surgery, and again, we're not that far from Ampleforth, had to undertake a personal safety review for our staff working, which is usually, if I'm honest, the doctors that late at night. It's to how do we protect ourselves as much as is ever possible from that sort of incident. So it is definitely at mind. And if you talk to colleagues in practices where incidents like the one at Ampleforth have taken place, what they say is actually people just leave. They go and get another job in a place that doesn't feel as threatening or as aggressive. People just retire earlier. And that's one of the issues around retention, and particularly retention of all staff in primary care that I think we're facing. Just want to quickly just mention the issue around high intensity and low intensity users. And you're right, part of this is we need to be more sophisticated at recognising they're very different. Claire Fuller, the National Director of Primary Care, yesterday mentioned an example where in her former ICB area in Surrey, they identified the 600 users of NHS services most likely to end up in hospital. They had, and I think these are the figures are right, Amanda will correct me, 450 outpatients appointment in the year between them. They'd had 1,800 A&E attendances. We all were asked to guess how many GP practice attendances those 600 patients had had in the last year. I guessed 10,000. The newly elected president of the Royal College of GPs, who was in the room, guessed 12,000. The actual number was 54,000 appointments in a year. So 1,800 A&E attendances, I think it was 1,200 admissions, and 54,000 GP centres. So we need to do some work to identify those people and to work out ways of making their care as proactive and as efficient as possible, working with colleagues around integrated neighbourhood teams, because that will have an enormous benefit to the whole system, especially in general practice, around capacity. With regard to low intensity users, one of the best things we can do is ensure that we have good, clear, consistent messaging available, not least on our practice websites. And one of the pieces of work that we are undertaking across all of our 6 places is to ensure that practice websites are up to date, are effective, are consistent in the quality of the information that they share. So if you only contact your practice once every 3 or 4 years, there's a very obvious source to where to go to know how to use that system most efficiently.
Thank you. I'm going to go Karina, Mark, then Jason, and then I think we're done. Oh, and Anya, sorry. Anya was first.
Yeah.
Go on then, Anya.
Just very quickly, I just wanted to touch on the NHS app. There is a group looking at this as a spin-off, and as the report says, it's great that we've got a higher than average number of people that have downloaded the app, but of course the key is that we want people to be using the app. A lot of people will have downloaded the app for the COVID passport as we were coming out and still within COVID. Quickly on the challenge is that not all GPs have signed up, so not all practices, should I say, have signed up to all the functionality, which makes it difficult to do a sort of broader communications or marketing exercise because it's variable as to which patients can access which parts of the functionality. But as a really positive, we have got almost full assurance that everybody has signed up to the repeat prescription. So that is an area that is going to be a priority in terms of some communications activity to really get those patients that can using the repeat prescription. So I just wanted to make that quick point.
Thank you, lovely. Can we just hurry along because I'm a bit worried about time. So is it Jason next?
Karina.
It's fine. Annie's just said exactly what I was
okay. So, Jason.
I'll be really quick. I just wanted to challenge a little bit of what Annie's just said about the app. So I think I really want to take some credit here on behalf of the voluntary sector for the work we did about getting people registered to the app, which was post-COVID. And I think that has kind of shown that how we engage differently with people, not with NHS leaflets, to say, this is how you use the app, this is the benefit of the app, this is why the app stops you ringing in, has been really good. And we need to continue to do that, because the interesting figure is not the 60%, which I'm really proud of. It's the 40% who do not have access to digital, which are the ones that we need to kind of be worried about. And actually, we can't give everybody a phone. And actually, we need to recognise that digital is great, but it's not for everybody. And we just need to kind of be kind of careful. But I think that's been really amazing. I think there's 2 things for me, one of which is the workforce issue. And I think we have worked really hard, and I think we have achieved that primary care is integrated into our breakthrough programme. And Jane will talk about it a bit later. Nigel is in Kerala at the moment looking at opportunities in terms of primary care coming into our wider partnership. And that's incredibly positive. And through the work of the Ethical International Recruitment Committee, which Andrew chairs, we're doing a piece of work around mapping around where we're currently doing international recruitment. And primary care is key to that, because the resource that primary care currently spends on international recruitment could be used differently by us as a partnership. And actually, how do we really, as a partnership, trust each other to recruit rather than kind of do it over and over again? There's just 2 things I want to kind of mention. One of which is, I think there is something about maximising resource in primary care. So actually, this is an overview from a system, but we know that parts of our system are not fully maximising the resource that's available, and we need to make sure we take everything into our system that we can. The other bit is almost the interface with patients. I think it goes back to Anya's point. So I remember the golden days of patient participation groups. You must remember, Emma, when we had a 100% success rate in Hull. There is something for me about really visiting that engagement model with patients, and actually the ability to have conversations negates the angry phone calls. And I'm not quite assured that we have gone back to the golden days of, and we haven't really maximised the digital opportunity we have with that. And I think that's probably, I no longer know where complaints go around primary care, actually how I interface with primary care as a patient. That feels we've got lost that in the shuffle, and that's probably a Health Watch kind of conversation. But I think part of the work moving forward is how we transform the whole of it, not just the workforce, but actually we start to say our messaging to patients has to be different. It has to be, you may get a range of options. It may be, you don't need to come in. And actually, unless we kind of do that in partnership with patients, we end up no further forward. They were just my thoughts.
Thanks, Jason. And very, very finally, Mark.
Yeah, just quickly, I thought that Simon's point about the focusing on the 600 patients was really interesting, and I'd be very interested to hear more about what we looked at in that space.
Yeah, thank you. Thank you all very much indeed. I feel that's been a really, really good session. Great to have you here, Simon. That was really compelling, really interesting. And again, with that earlier conversation, we know that it's by developing primary care, by developing care close to home, certainly outside of acute hospitals, that our future lies. So all this work is critically important to us. I'm just looking at this clock above the door. It's 1:54. We hoped it was 1:45. So we're adrift by 9 minutes. So shall I say we'll break now till 2:10, but I'm saying that on the grounds that when you come back, you have to work with me to finish for 3 o'clock. So 2:10. Thank you. we do have a little bit of a challenge now, timing-wise, but it's not a challenge that we can't meet, I'm sure of it. So let's return to our agenda, to agenda item number 14. You'll remember when we discussed the Let Be prosecution, we asked the question about our own freedom to speak up arrangements. We were interested in the freedom to speak up and whistleblowing arrangements in our trusts and the other organisations with which we work. But we were also interested to know what happened inside our own organisation. And today, Karina is going to give us an overview of freedom to speak up in our Integrated Care Board.
Yes, thank you, Chair. And in the interests of time, I will just pull out some salient points, if that's okay, and assume that the rest of the paper has been read. So the paper does set out that we have our freedom to speak up arrangements in place as an integrated care board. That has been in place and established since the 1st of July 2022. Our freedom to speak up guardian is obviously Nigel Wells, and he would have taken this paper had he been here, but he's ably supported by the legal and regulatory team, which sits within my portfolio, so hence why I'm covering this today. And obviously now we've got Mark back, we have our freedom to speak up non-executive director back in their role as well. I think the key thing that was requested was really an assessment of the current position for the ICB and what's happened since the 1st of July 2022. And it's just a bit of a reminder for the board that we actually also take freedom to speak up concerns from our providers and from outside our own ICB. So at the moment and to date, we've had 7 freedom to speak up queries raised, or what was perceived to be freedom to speak up queries. 2 of those matters remain outstanding due to ongoing investigations. 5 have been triaged and or investigated or are in stages of investigation. Of the 7, 4 are absolutely whistleblowing freedom to speak up concerns. 1 related to primary care, which was investigated thoroughly. We did that within a 2-week time frame. That isn't a usual time frame for these investigations, but we were able to conclude that one within 2 weeks. And for the assurance of the board, there are no outstanding concerns at the end of the investigation. And that focused on financial management and patient safety issues. There are 2 relating to acute providers and the safety of services. 1 of those has been completed to the satisfaction of the complainant. The other is an ongoing investigation which is linked with NHS England under the protected disclosure work, because only NHS England and CQC can have the protected disclosure element. But we are doing the work for that particular investigation. And then the final one relates to another provider which is currently being investigated. The conclusions of phase 1 we expect to be early December, which will be able to give us a better exploration of the issues, but we're within timeframes for that, but it's still an ongoing investigation. The other point just to make is that NHS England have issued some revised policy documentation around freedom to speak up. We've highlighted, just for people's awareness, that what our existing policy says, what the national policy says, and what our recommendation is that we are going to take forward to revise the ICB's freedom to speak up policy, and that will go to the Quality Committee for approval. Other than that, it's just to take any questions, Chair.
Thank you. That was really helpful, Karina. Stuart first, then Teresa, then Peter.
So mine relates to the number of queries that we had. 7 doesn't seem very many. Given the amount of angst there is in the system, we were hearing about violence and such like from disaffected patients earlier on, and we've only got 7 cases going through here. Can you help me understand why we've only got 7?
So that's because this is the ICB, so our organisation position. There may be other other organisations have their own freedom to speak up arrangements, so they may be dealing with their own queries. So the number could be a lot higher, Stuart, but this focuses on our organisation.
Maybe next time it comes back we could learn about the whole systems, sort of rate of incidence. There's a thing about if you don't hear complaints and you can't do anything about them, that's sort of behind my question.
No, it's a fair challenge. Of 700 people in the course of 15 months, 7 complaints isn't much. You're right. Teresa.
Actually, it builds on that. In the paper, it talks about the role of the ICB in the wider system. Arrangements about being primarily that there are appropriate arrangements in place within those organisations across our ICB. You may remember that I shared a couple of board meetings ago a working document from NHS England which is making more explicit with the changes happening at NHS England some of those cascaded responsibilities to the ICB. And I think I would word that stronger, so there's an expectation that we will formally assure the arrangements in place within providers in the ICB, and there's a responsibility on Nigel to ensure that there is learning across the organisation, so presumably working with the Freedom to Speak Up Guardians so that they have a sort of a network for information sharing. So I think there's a bit more work to do on that angle, which I think will answer your question, Stuart.
Yeah. And I'm sure both Simon and Michelle are intimately acquainted with their Freedom to Speak Up Guardians, with the information that comes through, with the trends that they look at. No doubt taking information to board, so there's probably is a way to triangulate that. Peter?
Yeah, thanks, Chair. This is a language point. Freedom to speak up is quite permissive language. There are some things which are a duty to report.
Yes.
So I'm thinking safeguarding and counter-terrorism prevent duty.
Yes.
So just in terms of how we're presenting this to staff, are we quite clear in policy that when things are a duty to report, not permissive?
Yes. Oh, that's interesting. Thank you. And Jason?
So I think it picks up on that, I think, Peter. So there is something for me about if 7 is the starting point and the baseline, then it's about what happens after the 7, isn't it? So actually I've got a question about how often this kind of gets reported and actually being able to measure peaks and troughs with it. I do think there's something about awareness raising around, is everybody aware of what Freedom to Speak Up is and what it isn't? Because you've got, as I suspect you've got HR stuff kind of flying into here where actually it needs to be kind of somewhere else, but that's because people feel they understand Freedom to Speak Up as being, I need to tell you something rather than actually what this is actually about. So I suppose I've got a question around what's that communication to staff so everybody's aware of, because actually your 7 could be based on the fact that nobody knows about it. So actually only 7 people know about it, 7 people report. So there is almost something around the action to just kind of almost, and Peter's point is exactly right. This is really clear in the guidance as to what it is, but actually clearly some people don't know that and they think it's something else. So I suppose it's that workforce bit, isn't it, Jane, where people are aware of it, how to use it, but actually are aware that there are other channels. So it's almost like a flow chart that says if this is your issue, this is where it goes, but actually these are things that you must take forward through formal routes rather than trying to do it through this process. So
I think it's also quite possible that the arrangements are very different in a world where people are broadly hybrid working. You know, and I don't know whether we've looked at our rules and guidelines since COVID, but we don't have people in a workplace, a Freedom to Speak Up Guardian who's around in a workplace, you know, all the things that you might traditionally have used to communicate. Yes, Mark, then Andrew.
Yeah, just if I could comment on the kind of number of cases, I think it's important to highlight the fact that these are people who've gone through the Freedom to Speak Up route as opposed to raised a concern. It's actually a HR thing that should be a grievance and should be dealt with in a different way and all that sort of stuff. And it's always very different. I mean, I think it's a good challenge to ask the question about the numbers.
Yeah.
If I reflect to my recent experience at York, where I did meet monthly with the Freedom to Speak Up Guardian, who also came and presented at public boards, didn't she? Yeah. You know, I think the proportionate numbers of cases was not enormous, but it was the appropriate things. So I think that kind of closeness, and particularly when I'd scribbled down Nigel, you know, meeting with the Freedom to Speak Up Guardians across the patch, and that all kind of linking together seems like a terribly good idea.
Yeah.
But I'm not sure we should be concerned by the numbers in isolation.
Okay. Michelle.
Yeah, no, thank you. I mean, I'm our Freedom to Speak Up Guardian, and well,
You're
executive sponsor. Me, because I think I feel really strongly about the issues around that cultural development. And we have got ambassadors throughout the organisation, actually, both those from, even if we're doing the hybrid working and working from home, etc. So we've got quite a lot of ambassadors. It's really difficult because it's a bit about, I mean, the 7 are there. I think it's useful to see a report in relationship to some of the detail. You can cross-reference that to some of the other quality data that Teresa said, because it's that metrics piece, isn't it? It's that triangulating. If you go back to the Letby case, it's about, you know, are we assured as a board that our organisations are implementing and developing their freedom to speak up processes enough? Because it clearly didn't happen, to be quite honest, in the Letby case. So I think for me that's what I would look at from an ICB point of view, as well as you need to the internal piece, but I think that's a bit smaller for me. And do you have some ambassadors at place, etc.? Just a thought. Or as well as that overview of just let's have a look at what the organisation's freedom to speak up processes are like. So I think there's 2 bits for it for me. And then obviously the 3rd bit is looking at the data. What are those 7 telling us? Are they telling us anything different in relationship to our quality processes and our performance process?
Thank you. Thank you. And finally, Andrew.
Yeah, I think it was that thing about not getting fixated that's been raised about numbers.
Yeah.
For me, low numbers might actually demonstrate a very effective management and leadership, well-led organisation, and that actually people are getting issues listened to, resolved and dealt with in an appropriate management sort of like hierarchy. And I just think it's a really good valve for when that isn't working properly, that people can be seen. I think you need to be assured that I think there's a real balance here between becoming regulatory and becoming assurance seeking. And actually at the end of the day, I think the assurance is the thing that I think I agree with Michelle, is that we should be assured that people have got the right and proper process, but actually it comes down to individual accountability and responsibility of the chief execs to make sure that those systems and processes are right, and because they will be the ones that are in the firing line if people are raising things and we're not listening properly, and especially after Letby. So and it just sort of makes me think that you could make an industry out of something that really we should be promoting, well led, and not to get into other people's territory. And I just want to come back to your point about with people home working. I don't know about anybody else's organisation, but because there was quite a lot of home working during COVID, we had all our numbers on, usually they come from sort of like internecine warfare between teams, do you know what I mean, who've fallen out years ago and have a grudge or something, and you find that actually they can't get any movement with that, so they go straight to the chief exec, whether you're not the, you know, whether you're somebody or not the freedom to speak up person, and say like this isn't working properly. But the point being is all those numbers fell right back because people weren't actually in teams in buildings and getting on each other's nips all the time, weren't they? So actually, they ended up sort of like, you know, HR sat around thinking, well, maybe this is a good idea actually, because you know, people actually are getting on in a different way. So it is quite interesting. It's not all negative. Some of it was quite interesting that it did take some of those interactions out.
We had the same discussion, didn't we, when we talked about fire deputies. You know, do we need those in the same way? It's just different, isn't it? A different way of working now. I think we want to hear about this 6 monthly, I think. So let's just make sure that we plan to hear about this again 6 months out. 3 very chunky papers now, very much down to the presenters of those papers to take us through it in the most economical way, but without distracting us from the huge importance of the subject area. So first I'm going to go to you, Emma. This is the finance report.
Lovely, thank you, Chair. So yeah, as you said, a really detailed report that's presented for you, and I'm conscious that you see this regularly. So I'm going to try and just pull out the salient points as we work through it. As Amanda said in her introduction, it's a very, very live discussion, is the money and the Jane is not here is because she's in London hearing about some of the next steps in terms of the financial landscape for 23-24. Just on that, we are expecting, and I'm conscious we've got a part 1 and part 2 conversation around the finance. So in terms of time, if people want to delve into some more of the detail, we will have an opportunity in part 2 to do that. But we are expecting to hear about any resource that's available to cover the impact of the industrial action, obviously, that's been in place across the financial year that nobody could have foreseen, or certainly foreseen the impact of. we're also expecting to hear about some additional resource that would be freed up linked to the elective recovery plans that are in place as well. And some flexibility around some service development funding that was earmarked at the beginning of the year for certain programme areas. We're expecting that some of that will be released for more flexible use in the financial year. But as I say, we can get into a little bit more of the detail on that in part 2. So in terms of the key messages for month 6, so this is the month 6 position. Just to recap, we've got a financial plan deficit across the ICS, so including the Integrated Care Board and all the providers that fall within the financial performance control total of 30 million. You can see on that very top line on page 1, the red, you know, we had a planned year-to-date deficit of 27 million and at month 6 we're already sort of approaching the 60 million mark. So, and again, I know you've had a number of conversations around that. We always knew that the plans, particularly the efficiency plans, were backloaded, hence why we had a heavily profiled deficit plan for the first half of the year. But even with that, we're seeing significant pressure that obviously we will need to think about in terms of the actions that we need to take to live within our means for the rest of the year. I'll come on to a little bit more about financial risk as we move through. So I wasn't actually going to say much more on page 1 or page 2 for that matter. So if I take you to page 4, it's the bottom of page 4, just to really sort of bring to life some of the reasons for why the financial position is so pressured. So you can see that we've got a lot of pressure coming out from the independent sector around the elective recovery programme, with some of the challenges that our NHS organisations are facing around these long waiting lists. What's having to happen is that patients are going into the independent sector, and that's providing some level of significant challenge that we're attempting to mitigate. And I think when we come to think about the longer term plan around how we deal with some of this, it's about having a really robust plan around repatriation of some of that activity into the future. You can see over on page 5, we've got within the ICB, we've got some really growing pressure around mental health services, out of area, high cost out of area packages and section 117 packages are, as usual in a system-based commissioning organisation, often an area of pressure, and this year is no different. We've got 1.3 million overspend on community services, just again to bring that to life. A lot of that is linked to community non-obstetric ultrasound activity, as well as community wheelchair activity that's done on a cost and volume basis. So we're seeing some pressure within that area of our business. Continuing care, again, another area of ongoing pressure that we face within what we describe as our influenceable spend of the Integrated Care Board. And again, this year is no different. And probably the biggest one that we're struggling to sort of contain and forecast, and again, that's not unique to this year, is prescribing. The data around prescribing is notoriously volatile. It's quite out of date. We're only working with month 4 information. So trying to draw conclusions and forecasts to the year end is really, really challenging. And I'll come on to a little bit more of that when we get to the risk table, if I can. Moving over to page 6, just picking up, I think it was Simon's point around where the money goes. I actually think this table 2, is a really good sort of description of where the 3.7, nearly 3.8 billion goes across our portfolios. And I suppose just reflecting on the point around the proportion of spend in primary care and the out-of-hospital environment, a lot of that has been distorted by the approach to elective recovery that's driven through the national policy. That means that a lot of any of the new money at the minute is coming through the route of elective recovery, which is going into the parts of the system that are not covered by sort of primary care and out of hospital. So it feels like the policy is a little bit out of sync with some of what we've been talking around, how we prioritise investment in the out of hospital and those wider determinants of health, which is something we're really conscious of. Page 7 really quickly just gives you an overview of the financial position within our providers. Again, and what we've tried to do is sort of just pull out and describe some of the drivers of the pressure, a lot of it driven by premium pay cost and the impact of strikes and other sort of significant areas of spend that fall within their responsibility. On page 8 you can see the table at the top, the graph at the top. I think this is a really good, it's quite stark because it shows that what our current run rate of expenditure would do if it continues, and what our plans for sort of stopping and stabilising some of that deterioration look like. But it really sort of starkly shows the challenge that we're facing with that gap at month 12 between what it would be if we do nothing and our plans for intervention. I was just going to very quickly just draw your attention to the table 3A and the section there, because I understand that's new to the report, because I think there'd been talk about understanding the financial position of in particular the community interest companies that obviously exist within this ICS. So just to recap, we've got City Healthcare Partnership, we've got Navigo, and we've got Care Plus Group. We've just got a bit of a timing issue with getting the others represented, but thank you to Andrew and his team for providing us with the position around CHCP, which you can see described here. So, and again, just to be absolutely clear, the community interest companies do not form part of our financial performance assessment. They show us an expenditure line within the ICB. So it was just to draw your attention to that. In terms of the efficiencies, again, you've got a huge amount of information and detail around the efficiencies programme. Again, when we come to look at the forecast and some of the work we're going to do on the back of some of what Jane hears in London today, I think some of it will be about recapping and re-understanding where the efficiency ambition landed within our system, for want of a better description, because I think it's fair to say that we did attempt very clearly to share financial risk proportionately and fairly across the system, both across the ICB and the providers, but really recapping and understanding what the start point looked like before we then look to reset a forecast, I think is going to be really important. And again, we'll be working with finance colleagues and operational colleagues in the coming days and weeks to get under the skin of some of that. I'm a bit of a cynic where efficiency comes from, because I do believe that sometimes it can be, well, I didn't buy the Ferrari, so I've saved £100,000. So again, trying to get under the reality of some of what is genuine and real efficiency is really challenging, and one thing that we're attempting to do really clearly. And we've obviously got the quality, efficiency and productivity group that is being sort of supported heavily by Rod Barnes now, that's looking and getting under the skin of some of the challenge linked to the efficiency ambitions that we've got. The only other thing I was going to say was just on the capital position. We've got here within the appendix at the back, I think I'm talking now at page 17, a really clear view of what the capital's looking like. We are looking that we've got an underspend at this point, I think in the order of something we're forecasting at the minute, about 25 million, but we've absolutely got plans to catch up on that investment, and so we're forecasting that we will use all of the capital resource within 23-24. I know that when we've spoken to Stuart before, one of the things we're going to attempt to do is make some of this real. I have actually got some real examples of what the backlog maintenance expenditure goes on, and again, happy to take any questions on that. I've cantered through that. I'm conscious of time.
It was really, really helpful, and you did a really lovely job of it. So thank you,
okay.
Emma. I will take questions, but I'll take brief questions, please. So Stuart first.
One's a clarification. When I say real, I just mean names of things that you can, in capital, that you can point at, you know. There is a new A&E department in such and such a place, that kind of thing.
So the live example I've got from Hull University Teaching Hospitals, their backlog maintenance has been heavily supporting some of the theatre, critical infrastructure,
right, to bring it to
life.
The other one is one that I've raised before, but
yeah.
Would it be right to say that we are sort of under instruction not to change our forecast at the moment until the stuff that Jane's dealing with is sort of properly understood?
Yes, that's absolutely right. And I think my sort of reflections are that there are still some really material parts of the financial position that we don't understand sufficiently to make that certain judgment, and those three are the money that we're going to get around industrial action, the elective recovery, and some of the more flexible use of that resource. Once we know what those numbers look like and mean for the ICB and our providers, we will then be able to take a view on whether the ask of NHS England to live within our means or not is achievable. And just to say, we've got a timescale of about the 20th, it's coming out now, the 22nd of November for some initial assessment of that. So we're going to be having to work really fast to assimilate what comes out of today into the plans and the position that we've got.
Does that mean we might have a revised forecast for the December board, or when?
I think it's looking likely.
It'll be month 8, so it'll be, yes, probably around about or just after the December board.
Yeah.
Thank you.
There's no doubt, is there, that 57 million adrift is a long way off a break-even. So there's no doubt that we are under enormous financial pressure. Most of you will know that we've instigated a monthly extraordinary meeting of the board along with our chief executive colleagues to talk about and try and push forward in terms of the financial position. And we will, in the private board, talk a little bit more. But I wouldn't like anyone listening to this meeting or watching this meeting to think for a moment that we weren't taking that financial position very, very seriously, because we are. So many thanks, Emma. You did a nice job of that for us. Now to performance, Amanda, please.
Yeah, thanks. So I'll be really quick, and then Sean has got any detail that colleagues want to ask in terms of questions. I'll take the paper as read. We're getting quite familiar, I think, with this performance report now and the story that it tells us. We do still have some significant areas of challenge. So I just want to pull out some of the key areas we might want to look at. So in terms of urgent emergency care, we still are challenged in that area. So the 4-hour standard is 68.1% for the ICS. We've got 2 of our trusts, Harrogate and Hull, are the most adverse from their plans, and both of our ambulance services are not currently delivering the 30-minute Category 2 target. And actually within the North Eastern Yorkshire region, all of the ICBs are behind their recovery plan for the UEC 4-hour target. And then in terms of the waiting list continues to grow, although for 65 weeks we are ahead of our plan in terms of that area. We've got some revised guidance on the elective recovery fund, so we are actually doing quite well on that, but the guidance we will take consideration of in our response to that. We do still have some challenges around accessing diagnostics and some challenges in relating to cancer treatment. Just in terms of leadership around these areas, what we've agreed with Simon Morritt, Jonathan Lofthouse and Jonathan Coulter and myself is that we'll split SRO responsibility for urgent emergency care, elective recovery, recovery of the diagnostic waiting times and the cancer performance between the 4 of us, and take a lead role in terms of that. So there's a number of pieces of work that have kicked off around that, particularly around elective and urgent emergency care, which we need to grip. And just one other thing to flag, which is a green shoot, is that in terms of access to dental services, we've increased by 6% since the last time to 88%, and there's a significant plan around improving that. So I'll take any questions on detail.
Thank you, Amanda. Of course, the thing that we have to be really minded of now is that this is we're reporting on the end of October, aren't we?
September. Yeah.
So we've had October, we're now in November. You know, there's a lot of winter to go, a lot of respiratory illness, a lot of cold days and cold nights and damp houses between now and the spring. And we know that really, really impacts the way in which the public need to use health services. I don't know if anyone wants to ask any questions, if there are any comments. Stuart?
There's a few areas where nationally targets haven't been set or properly defined, and I've had a bit of dialogue with Sean on this matter. I think it was when we looked at maternity where we've got targets not yet set, and yet we're all worried about maternity.
Yeah.
So, Sean, I wonder if you want to just help us with how we might get to grips with the fact we haven't got targets set, and therefore we're not seemingly...
Yeah, I'll invite Teresa to answer the specific question about maternity, because she's definitely more of a maternity expert than I am.
So, there isn't a target as such, but what we could put in here is the national rate, so that you've got something to judge where we are against that. And our goal obviously needs to be to reduce our position, but it'd be important to understand us against the national rate. In our private board later, I'll be talking about the difference of the different units, and at the moment that's obviously just the rate for all neonatal services, and all neonatal services are not equal. So we need to do a bit more drilling down to explain some of this for you, but I'll do some of that later.
Chair, just on Stuart's broader point, there's 31 measures that were indicated in the planning guidance for 23-24. There's a number of complex national reasons as to why, as Teresa just illustrated for maternity, why that's not quite manifested itself. But I think Stuart's point is, can we try and put some proxy measures in place to try and give us a sense of that in the absence of that? And I think we will endeavour to try and do that for some reports.
I think we have asked for this on a number of occasions, to be honest. I think we've been talking about this for about 6 months, so I'm glad that Stuart's raised it.
Yeah, I mean, I think part of it is because nationally they've indicated that it would be forthcoming, and that's not materialised in the time that they initially flagged. So clearly we'll have to look at alternative arrangements. I think just to add to your point, Chair, about the fact that this report takes us effectively to the halfway point of the year, and in a number of areas, take diagnostics for example, our challenge at the beginning of the year has either remained static or deteriorated, and certainly there are other examples of that given various pressures. Just on the cancer 62-day, which is one of our particular challenges, there's additional resources going to be made available to help with our improvement trajectory on that. And I suppose the other thing to say is that a number of these areas have got recovery plans to try and move things forward in a positive way. So from an assurance point of view, just from a board perspective, just be reassured that we are taking proactive action across a number of these areas, but combined with the financial pressures, industrial action and other factors, they've obviously helped put further challenge in the system along the way.
And what I understand from providers is that we feel worried about the acuity of the patients that we're seeing. So maybe not more patients, but very sick patients. We're worried already about no criteria to reside in our trusts. It's already feeling difficult, I think.
Can I just add something to that? So one of the things that is there's multiple sources of data, particularly around UEC and understanding it, and there's a lot of anecdote. What I've asked Jack Lewis and the inequalities team to do is a piece of work around all of the data to get a true picture so we understand it. Because actually, when you look at the data in granular form, the ambulance numbers attending REDs are broadly flat. The admission rates are broadly flat. So actually, we're not understanding that. We've got more alternatives to ED than we had previously. We've got a lot of additional community beds we didn't have previously. So it's trying to understand all of those things to make sense. So we're doing that piece of work now.
Okay. Do you think we'll have something to see next month?
I don't know if it'll be next month because there's a series of 3 workshops with all partners around understanding it, but certainly in 2 months' time, but it's an ongoing piece of work.
Okay.
If there is, we'll certainly share it.
Okay, thank you. Anything else around performance? Jane, item 17. We've been waiting for you for a long time on that screen. Anyone else who's been looking at item 17?
It's been there a long time.
Finally, we've got to you. It's you, Jane.
Yeah, thank you. I'm not quite sure how to counter through this at great speed, but I shall do my best. There's a few slides to share with you, and you'll remember that you've had a number of presentations on this as this has been unfolding. We're just over halfway through this year's breakthrough programme. So if we go to the next slide, please, Mike, thanks, and the next one after that. So if you remember when I last presented the breakthrough programme for this year, which built on 180 days, was all about how our workforce and how they were feeling, and particularly linked to the development of some measures that we were going to work on. So if you've got these in your pack, so if you're interested in the colleague stories, you can scan the code and it will take you straight through to them. But our overall aim in this 5-year programme, year 2, is to shift the dial really on how people are feeling coming to work and working in our environment. Next slide, please. And we know we've got Professor Michael West coming next week to our retention conference. If you remember, in 180 days, we did some work on understanding what was causing people to leave our organisations and what was driving that. We've been doing further work on that and developed that into a conference. So we're really chuffed that he's coming to speak at that. But his research really clearly shows the importance of the work that we're doing. So the voice of staff being the most important voice that we must listen to, and the evidence base that says that staff experience is ultimately linked and intimately linked even to outcomes for patients. So I think it's worth setting the scene for that before I jump into a bit more of the detail that we're trying to generate.
Jane, how many people are coming to the retentions conference? And are we seeing that as a conference for all leaders, not just an HRD thing? Or
it's not just a HR thing, no. It's the retention work stream as well that's generated it.
Okay.
I've actually got my pre-meet tomorrow, so I couldn't tell you the final
okay.
numbers. But we know from when we last met that the retention work attracted a huge interest.
Okay,
So,
great.
yeah, I can let everybody know.
Where's that taking place?
In York, Principal Hotel in York.
Lovely.
Next slide, please. Professor Michael West, by the way, has done quite a lot of work with some of our local organisations, certainly when they've been developing some of their leadership approach and thinking around the leadership approach. So he's a good critical friend to us in Humber and North Yorkshire. So what does that impact look like? And you know we've been grappling with this for some time. So how do you translate what has been predominantly about relationship building and working together into some hard metrics? And there is no easy answer to this. So if you do the next slide, because it'll all reveal itself. Mm-hmm. So we are working and looking at some of the hard measures like staff in post, vacancies, and those that you can see across the top. And this narrative, which is in your pack, just explains what each of those means. Next slide, please. And next one. That's it. Makes it much easier to explain all in one. So that's across the top. Down the left-hand side, I've tried to plot all the different staff groups that we are trying to collect data around to make the point, really, that we're data-rich when it comes to secondary care in most of the data that we talk about. When we talk about data, even in the performance report, is all secondary care. And we're trying to collect data across all of these other workforce areas, some of which we're having some success on, some of which is our own evidence base that we're creating by doing the work that we're doing, and some of which we only get annually, and pulling that together to tell the people story. So you'll remember we did a little bit of conversation around the people story before. So you can see how complex this is to try and get a whole picture on workforce, and that it's still a work in progress 6 months into this year's work. But I wanted to show you that so you can see the work that's gone on to it and where we actually do now have data and where we think we will get a lot more data through our research. Next slide, please. And just do the next one as well, because it'll just bring up all these, yeah, let all of these unfold. Just makes it a bit easier. So the evidence base that we know that we've now got is those boxes that you can see, the 1, 2, 3, 4, 5, 6, 7, 8 boxes. And we know, therefore, the impact that some of those then has on retention, leaver rate, absence, and that then links through to vacancies and use of agency. We've got some really good data, though. So we had the inequalities and attendance report that was done across North Eastern Yorkshire, and that evidenced really strongly that we will have a longer, slower recovery from the trauma of COVID than other more affluent regions. So linked to health inequalities that we were talking about earlier, and the direct link across from that. We also know from the RES and the WDES, which is predominantly through our acute trusts, that we're showing ongoing poorer experience and progression for colleagues from minoritised communities and the other elements that you can see on here. But it does actually all link together. And if we go to the next slide and press it again. this will all just suddenly reveal itself. So you'll get green and pink boxes, well, the purple really, but they look pink on your screen. So that same track and where our work is impacting on those areas that we know is evidence of how our colleagues are experiencing being at work. So the pink stroke purple ones are our committees and the green ones are our breakthrough programme. So the work that we're doing on each of those programmes, and I went through this the last time I presented alongside the long-term workforce plan, if you remember, that showed where some of those interactions were. So what this shows really in quite a nice way is that we have work going on in all of the areas that we know is what is hindering people's ability to enjoy being at work or want to come and join us in health and care. Next slide, please. These are the breakthrough deliverables that we are aiming on achieving this year through both the breakthrough work streams and our committees that are sat at the back. There's the details there for you. I know you probably will have read this, so I won't go through each one, but there's quite a significant piece of work. For example, the portability agreement I would pull out as one that we see as really critical, having a shared MOU and a recruitment toolkit actually that helps people move around our system and breaks down some of the barriers that we know we've got. So not having to have honorary contracts, for example, when people are moving, enabling that movement to go. And that's almost at conclusion now, Jason, isn't it? So we'll be talking to Chief Exec shortly about the output of that, and there are many others sat in there. We already know, for example, that Nigel's in Kerala at the moment, along with Kevin Anderson from Primary Care, speaking to medical schools over in Kerala around primary care and the ability to work closer together. And we've already had 102 international colleague arrivals from last November and this January, and we're just recruiting again at the moment. Andrew, you lead on that for us in our system, and we're doing that in a really ethical way, and a lot of our organisations have already achieved qualification in those ethical standards anyhow, so we're in a good place with that. Next slide, please. This is the last slide. So just to plot it on a washing line, really, through, because that's what it sort of is, really, so that you can see how all this fits with the different elements of workforce. So trying to inspire people, attract people, recruit people, onboard people, support them, develop them, retain them, and release them well, and where the different work streams are actually making a difference. We are, though, working on connecting our outputs together so that it's more of a coherent whole. Part of the challenge of when you do work streams is they tend to work in their work streams, and making sure that there's that cross-spread across those work streams is really, really critical. So last comments before I take any questions. There's 3 key points, really, from everything that I've just shared. So just recognising that some colleagues have a poor experience of working in health and care, and the work that we're trying to do around that. Really working hard at trying to get the workforce metrics that will give us some hard evidence around the work that we're doing and the impact that it's having, and making sure that the work that we're doing addresses those dimensions of staff experience that leads to people not being at work. And the very last point is we've got 2 system measures that is agreed with our organisations, and that's around sickness and around turnover. And we're doing well with sickness, we're beating our target, and not as well with turnover. It's above target at the minute. I'll stop at that point.
Well done, Jane. Thank you. It was a great presentation to read. I enjoyed reading it. It was really clear. Thank you. Are there any questions for Jane? Stuart?
You mentioned ethical international recruitment.
Good.
One of the things that one reads about in sort of long-term health is having a good job and a reliable income and all that sort of stuff. So across our system, where NHS money ends up paying for the employment, or indirectly, we have good employment practices that would be conducive to that factor in long-term health? Or do we have 0 hours contracts all over the place?
No, I mean, we do have good employment practices. I think it probably is worth saying, because you started it by saying ethical international recruitment, and we are working hard at that, but we only see that as a short to medium term solution. We're also working as hard at recruiting from within our own system, if you like. And we've got some work with Hull and East Riding LEP, trialling out in local schools a pilot that will expand wider if that if that works well. I mean, the NHS part and local government and others have excellent employment policies, yeah. It's not necessarily how people feel, however, when they work. So having policies is one thing.
Yeah.
Having, you know, line managers that you trust, the right training, flexible work practices. I mean, you could go on, couldn't you? They're some of the keys, really.
Yes, Jason.
So I suppose there's just a couple of kind of wraparound things. I mean, part of what this is about is that we have the most amazing talent in our system. But actually what we don't use is use our talent in the best places. And actually we make it really difficult for people to move from place to place. So we're very much focused on roles, not skills. And our future workforce has to be, this is the skill that I need for this particular task in this particular time. And we need to be able to move that across without any inefficiency. And we've got people in our system who are being held up moving from organisation to organisation because they've got to do all the mandatory training again and they've got to have another DBS check. And actually some of this is around how we start to have a shared workforce strategy that isn't about stealing people from elsewhere in the system. And I think the Jean Bishop example is a really good one, where actually we should be able to put the right resource from different organisations in one place to deliver a shared service without having to kind of think about different types of contracting and changing things. So there's a real appetite for that, but we need to kind of make that happen. There's something about how we maximise the resource we have around workforce. So we do have resource around workforce, but actually we need to spend that wisely and well. We're not as rich as we were in terms of workforce, but actually the key word is investment, isn't it, Jane? So it's about how we invest in future workforce. And then the other bit, and I suppose it's the bit that you don't see from this, is all of those different kind of things on our washing line are led by different people in the system. Yeah. So the system leads this. So the ICB convenes and supports it, but Andrew leads ethical international recruitment. Education and training is led kind of by the University at York and by Hull College. Actually, what we've done with this, and it's the how, not so much the what, by bringing people together with a shared purpose and saying, on behalf of the system, lead this piece of work that brings together people from chief executives to people who answer the phones, who are interested in the area. That real difference in how we behave as a system and impacts on how we behave in terms of our workforce. And I think that's been deliberate in our design. And everybody who is leading that piece of work, you know, huge thank you. It's all about balance. So we have to balance international recruitment with grow your own. We have to kind of really make sure we invest in our current workforce as well as our future workforce. We need to really think about the barriers. So for those people who are furthest away from employment, who will never complete NHS jobs, actually how do we go to communities and recruit from communities? Because this is all jobs. It's not, forgive me, all doctors and nurses. This is porters, people who do the cooking, people who answer the phone. This is actually our future shared combined workforce that could work everywhere. And I think the progress we've made in the tangibles, we are starting to kind of see that difference. Feels a bit exhausting, but we'll start to plan for year 3 now. So year 3 will be a different set of priorities which the system will set itself. The foundation blocks that enable us to do the stuff that actually in 5 years' time is going to give us that workforce of the future, and those metrics will look very different in a year's time.
Great. We look forward to that. Thank you. Bushra.
I just feel a little bit uneasy about the way that we maybe talk about where international recruitment sits and what our preference might be. And I worry that an international recruit might hear that and think, actually, I'm not really what they want. I am secondary, not as good, and that wouldn't be an ethical way of employing anybody, making them feel from the start that they're not really what we want and that there is better, and that in a few years' time, when we've sorted out our local recruitment issues, those people will no longer be welcome or required.
Jane? Andrew?
We're all over this, aren't you, Andrew?
Can I jump in as well?
Yeah, you go.
Okay. I think you raise an important challenge. I think it's a bit of a leap to go from what we've said to that's what we're doing because we know it's going to be a combination of all. But it is really important that we make sure that all people are welcome in our organisations and in our system. So it is a good challenge, but that's why we're calling it ethical international recruitment as well, to make sure that people do and are integrated. And I think I said most of our organisations have already been assessed for their ability to ethically recruit and the pastoral support that they give. And we'll keep an eye on that. So that would be, I know Andrew will have more to say around it.
Yeah, I think it's more, Bush, just to give you some assurance that
it's about getting that balance, isn't it? But it's also what we were talking about previously, about making sure that the people we get, we look after properly.
Yeah.
We give them adequate training, support, guidance, and then we don't just stop supporting when we think that they're absolutely settled, because that is not the case. And that actually through that pastoral element, which is more important sometimes, and you've got to get the recruitment right, but the pastoral ongoing care is the thing that will keep, you know, these are people, everybody's extremely important because we can't get them. Where we're trying to get from is this bit about concerns that have been raised here before, where you just keep going to countries that really do need people to look after their populations, and we've got a major problem, is that we do also have, with some caveats which are mainly home office or whatever, parts of our population that are already here, who have legal right to reside, but also are, say, are more longer-term residents of our communities that are feeling worthless, not feeling like they're contributing and not feeling like that but they've got a lot to give and they really want to give something back. And it's about how we utilise, balance that expense from going to places like Kerala with balancing the expense of supporting some of the charitable organisations that are really working hard with some of our refugee doctors, but expand that to refugee nurses, physios, the whole gamut, and then maybe get that balance. Because I think this isn't just about, I think the relationships that have been built up in Kerala are fantastic. You don't want to lose them, and you don't want to lose that ability to be able to share best practice across continents and maybe share things in a different way around workforce, but also really sort of like balance. But there's nothing in my mind that says you're not good enough and now I've got somebody else at all. It's like, actually, no, this is really key. You know, we're taking you from somewhere, we've got to really look after these people, or they will just... And some of them are absolutely, I mean, because of the chance and opportunity, they're extremely motivated, aren't they, to do a really, really great job, which I think is, we can't lose that, but we can't not look after people, I think. And it's not just a job of finishing, it's a job of then going on, and then how do we look at what we got? So it is a balance that we get young people in, we get those that really want to work. It's really bizarre, because I got fed back today from the whole place-based. You know, the local authority is extremely concerned about the number of people that are becoming unemployed, who are out of work. And I'm just saying there's something still missing at that place level where we're not really stimulating the understanding in some of these communities about what might be on offer in our services. Because if they're worried about so many people being on the dole, and we're really worried about how many people we can get into some of these jobs. They're not going to be ready-made individuals overnight, are they? But at the end of the day, we should be using all our resources to focus on them, our populations, and really getting that mix of the right people to bring some positives to our...
And you've spoken on a number of occasions about better integrating qualified people who find themselves here with refugee status.
Yes.
And how best to enable those people to have dignity of work and the prosperity of work, but also support us in our challenges. And I'd be really pleased to hear about any further development of that. I am going to draw that conversation to a close.
Got 2 more items, Chair.
Oh, sorry.
3 items in the same.
That bit I'm drawing to a close, Jane.
So one's really quick. One's in your pack, you'll also have that, which is the monthly update on the Workforce Board meeting. You get that every month, usually for information. The blue links take you through to all the detail. Please do look at it, because it does give you, when I'm not presenting at board, the detail of what's going on in all of the programmes. So I just wanted to point that out. And then my last item is the Sexual Safety in Healthcare Charter that's in the same item. So you have in front of you just a short paper. There'll be further to come, but just to get agreement in principle to signing up to the Sexual Safety in Healthcare Charter. The paper is really self-explanatory, so I don't think in order of time I need to go through any details in it, unless people have got questions that they do want to ask me about it. It's jointly with you, Teresa, but I would recommend to the board that we do sign up to this. I think, Teresa, you would do the same.
Absolutely.
This is the document that I was recommending earlier that I think everyone should have on their desktop and everyone should be able to refer to. It's really, really effective. And if you don't have a similar thing in your own organisation, why not use this as a basis and a start point? Really, really good, a really quality document. And of course, I can't think of any reason why we wouldn't sign up to that charter. Is there anyone who feels differently to me? No, of course we should do that, Jane. Thank you.
I'm done now, Chair.
I didn't mean to hurry you along in that way. Thank you all. We're on to item 21. This is where we look back on the BAF. I'm doing just that now. Oops. Oh no, item 18. I'm so keen that we get finished.
Sorry, I'll be really quick.
I've got 1721. Where's my page 18? My item 18. I've lost it. Oh, there it is. Item 18. North East Lincolnshire Health and Care Partnership. Please, Karina.
Me.
Oh, Amanda.
Okay, so really quickly, colleagues that were here last month will remember we had a really detailed presentation from the team at North East Lincolnshire and a discussion about the partnership and the delegation. So and there's a really detailed presentation in the pack, which is the presentation we went through in detail last time. So I'm just going to go straight to the recommendation. So we are planning to establish a formal partnership agreement between the ICB and North East Lincolnshire Council, underpinned by a Section 75 legal agreement, and establish a joint committee. We're going to do that and work in shadow form in Q4, and we're going to continue to work on the detail of what exactly is in that Section 75 agreement. And we want agreement today to support the proposal to have that shadow form operating in January whilst we continue to develop it, and then look to formally establish that joint committee from the 1st of April. But there will be a final report on all that work and final approval sought for delegation in February in the board meeting in public.
Okay, lovely. Any comments on that? That meets your approval stand.
You'd be surprised if I didn't comment, I think, and I'll keep it brief. Well done. I absolutely support it.
Thank you very much.
Great, thank you. That's terrific.
I did say it'd be brief.
You did,
yeah. We're well informed, I think, about this, aren't we? And
Yes,
well,
we are.
well cited on the benefits. This really is you now, Karina, isn't it? Item 19. Two things for you, I think, here.
It is, Chair, thank you. And members of the board will note that we've tried to reduce the number of policies coming to the board, but these two are particularly important for the board to approve, particularly in respect of the petitions one, because that relates to the Constitution, and we have provision in there for receipt of receipt of petitions. And members will note a couple of months ago we actually received our first petition as a board. We were basing that on old CCG policy, so we've just updated now to make sure that we've got a full, clear set out policy with roles and responsibilities, the criteria for a valid petition that we can receive. So it's really just for the board to approve that policy. The second one I want to just spend a little bit more time on, if I could, which is the artificial intelligence policy. We've recognised, and I know we've had many presentations here about artificial intelligence, and we know that our staff are using artificial intelligence to support them in their work. Therefore, we thought it was really important to make sure that we got the ethical and responsible use of artificial intelligence wrapped up into some policy for our organisation. We've tried to keep it really high level but really clear guidelines to make sure that it's not restricting people completely, but they are using it ethically within the letter of the law in terms of protecting personal data and mitigating potential risks. Particularly, we don't want to see people using it with personal information or with commercial sensitive information or anything in that sort of order. I think we're a bit of a trailblazer in this. Not many people have attempted this, so it is, we expect to have to update it as governance emerges and other things appear, but we really wanted to get something out there that we can then communicate to staff so that they know that they can use it safely and ethically.
Yeah, importantly.
So they're both here for approval.
Thank you. Can I seek approval then for both of these? Yes, go on.
Is it an AI quirk that the EQIA is blank? There's nothing there.
Oh, is that in the PDF?
Blank pages, yeah.
I've just got blank pages as well.
Oh, okay. No, it must be a quirk of PDF in the documents. It's definitely there in the Word one.
Didn't pay for the registration.
Yeah, we obviously.
Yeah, it's not on the PDF one. So.
No, it's not.
No, I trust you in the caveat of the conversation about EQIA. But
I can circulate the version round.
Greatly, far too long.
Yeah, no, there is a definite EQIA that is completed for it, and we can circulate it. That's not a problem.
So I would say that by email then, if anyone's got any exception that they want to take to the document that Karina shares. Thank you. Any more, Karina?
No, that's everything. Thank you, Chair.
There are some items for information. We've got our good news briefing, as you might expect. We've got our first stab at the corporate calendar for next year. That's got the big meeting dates on. We wanted to get that out early to help you with your planning. Although I expect many things have had invitations pinged into your diaries. Mike, there's something around public questions and answers for this board. Don't you want to say anything about that?
It's live on the ICB website now. To enable people to submit questions to the board, and time permitting, we will endeavour to facilitate real-time answers, but we will keep a transcript of the written answers and they will be available on the website as well.
Okay. And finally, information around the York Health Mela, which was an absolutely terrific event, and I was bold enough to say at the time it'd be great if all our places did just such a thing. Anyway, just putting that out there. When we look at the BAF, we have covered, to my satisfaction, I think, nearly all of the key areas that we discuss in the BAF. Everything has had an airing. But what's been most important about today is that we have focused not just on our here and now issues, but also on those things which we know will move us forward and actually are the solution to many of the problems that we face. So thank you all very much indeed. Back to normal next month. Next month we are meeting in private. Thank you all very much indeed.